after I started this talk, I kind of reflected back on my career. First off, I am probably been in nursing longer than most of you have been alive. This summer, it'll be my 40th year of nursing. So, yeah, that retirement date is moving closer. And I actually have been oncology certified. I went back and looked since 1990. So I was in kind of the second group in the whole city that became certified. And I remember standing outside, it was a spring day. One of us was so nervous she threw up. And we were at UNO, and we took the test with pencil, and mark the bubble. And I felt so stupid when I left that test. But I passed. So if I can do it, anybody can do it. And the other words of wisdom I will give you is that always keep your CEUs. I've been audited the last 3 times when I recertified, and they come in real handy. So anyway, I'm going to talk about, well, both of us are going to talk about health promotion screening and early detection. And that's 6% of the blueprint. So not a great deal, but you're going to get some questions. We actually made some sample questions that we'll pass out after our talk. Try to do them first before turning over and getting the answers. I'm going to cover the health promotion, epidemiology, prevention, and screening early detection, which is really dry, and Hope's going to cover the really interesting part. So I'm going to talk pretty fast because I want you to get to the good stuff. Health promotion definitions there. Are they going to get copies of these slides at some point?
They're online.
Okay, so if you want anything, if I go through it quick, you can get it online. Is behavior, back to health promotion, it's defined as behavior motivated by the desire to increase well-being. It's actually an approach to wellness. Illness prevention is behavior modified desire to actively avoid illness, detect it early, and maintain functioning within the constraints of an illness. This I know you can't see, so you're probably going to have to go online and see. But it's kind of the schema of what health promotion is. It goes into behaviors and factors and outcomes. But health promotion focuses on helping people achieve higher levels of well-being. It really encourages health professionals to provide positive resources to help patients achieve specific behavior changes. And the goal isn't necessarily to prevent illness, but to look at ways that people can pursue better health or ideal health. So epidemiology, we've all heard epidemiology this last year with the Ebola stuff. But that's the science that studies the pattern, causes, and effects of health and disease conditions, usually in defined populations. It's really the cornerstone for all our public health because it identifies risk factors and then targets some sort of preventive care. And it's helped develop a lot of the methodology for clinical research and public health studies. So to take that to cancer then, cancer epidemiology examines the frequency of cancer in populations. It looks at the roles of certain risk factors that contribute to cancer rates, and we'll get into that in just a minute. And then it also looks at the association that exists between the host, the environment, and other conditions that either lead to the development or inhibition of cancer. So some at-risk populations that we found out because of cancer epidemiology is that cancer is really a disease of the old person. People over the age of 65 are 10 times more likely to be diagnosed with cancer than those under 65. If you have a personal or family history of cancer, you're more of a risk, and Hope will get into that in great detail. Tobacco users. Some types of viral infections, the one that most often we think about is HPV and cervical cancer. We know that certain occupations can put you at risk. If you're in a certain type of manufacturing, or if you mine, or if you make pesticides, you could be at risk for certain cancers. Radiation exposure. And that's not just from ultraviolet light from outside, but back in the 50s, there was a physician in town that got this new radiation treatment, and they thought it could cure a lot of things, and they used it for acne. Well, as we've seen now later, that put those women at risk for maybe breast cancer because they didn't know about shielding and that sort of thing. Certain ethnicities are at risk, and I think Hope might get into that a bit more, a tiny bit. But one prime example is African American males are at a higher risk for prostate cancer than Caucasian males or Asian males. So the screening for that for African American males is different. And then, as you can imagine, socioeconomic factors always play into at-risk populations. So when we talk about cancer prevention, primary prevention is we want to take a healthy individual and decrease their rate. So we recommend certain screenings, and I'll go into those later. Secondary prevention is when we identify a high-risk population, whether it's a genetic family or an African American male, and we do some special screening that are targeted for the cancer that they're at risk for. And we maybe even if they're diagnosed have certain treatments. And then tertiary is when somebody's been diagnosed, like say with colon cancer, been treated. We do different things to screen for them, like say we might even do a different diet for them to help it prevent any complications or further cancers. So I took some of the most common cancers that are seen, and the American Cancer Society puts out facts and figures every year. Bladder cancer, if you're a male and have maybe worked as a mechanic and smoke, you're at risk. If you're a female and you're getting towards the middle of 60s, you've used hormone replacement therapy, have a mother or sister with breast cancer, and have been on hormone replacement for many years, started your period early and went into menopause late and never had children, you could be at risk. Now those are all varying, but the biggest one is being female and increasing age. Cervical cancer, we know if you've had the HPV virus, you're at a greater risk. STDs can put you at a greater risk, or having multiple partners. Colorectal cancer is the third most common cancer for both male and females. Obesity, getting older, using a high-fat, low-fiber diet, again, family history. History of having some colon polyps or maybe an inflammatory bowel disease can put you at risk. Lung cancer, leading cause of death for both males and females anymore. Cigarette smoking, we know that now. 40 years ago, 50 years ago, it wasn't so well established. But there's certain occupational exposures, like I mentioned, mining can put you at risk. Some manufacturers, the biggest one that I can think of that comes to mind is back in the 50s and 60s, they used asbestos. So those people were at risk for mesothelioma. Secondhand smoke and radon exposure are some of the two of the newer risk factors that we know. Oral cancer is a cancer that we're seeing more and more of. And again, we go back to cigarette, cigar, pipe smoking, use of chewing tobacco, but even HPV virus we're finding can lead to oral cancer. I'll let you think on that a minute. I have this cervical stenosis, so I get a little breathy, and I apologize. Endometrial, uterine cancer. Long-term, of course, female. Long-term use of estrogen replacement, obesity, high blood pressure, or if you have diabetes. We know, without a doubt, that exposure to ultraviolet radiation puts you at risk to skin cancer, and that includes those ever-popular tanning beds. There's an initiative within the state of Nebraska. What is it? The bed is dead. Yeah, that's gone to the legislature a couple of times, trying to limit the amount of exposure that especially adolescents have to that. Melanoma, which is the biggest form or the deadliest form of skin cancer, is also related to ultraviolet exposure. The family history and dysplastic nevus syndrome, along with how close you are to the equator, also plays a role. So here are some of the best preventive health behaviors. And of all of those, the best one, don't use tobacco. We have a tobacco cessation program that is, I would say, underutilized, but it doesn't matter how many times you approach a person that's a smoker, and it needs to be done by multiple healthcare providers. So if you ever come across a smoker, don't feel bad about bringing up stopping to them. The more times they hear it. Know your family history, and Hope, again, will get into that. Avoid use of hormone replacement therapy, and consider the HPV virus. Of course, don't use tanning beds, and avoid those high sun times between 11 and 2. Maintain a healthy weight and exercise regularly, and keep up with the recommended cancer screenings, which are going to be on the next few pages. These are the most recent cancer screenings for women. I'm just going to run through them quickly. They're on our cancer screening guidelines that are available just everywhere. The biggest change in the last few years has been the Pap test and pelvic exam. If you've had a number of normal, negative Pap tests, it's thought, and if you discuss it with your healthcare provider, it's thought that you can go down every 3 years. That's controversial. And again, these screenings are not based from that U.S. Preventive Task Force. They're based from screenings developed by the American Cancer Society. 40 to 60, you start mammograms for women. At age 50, it's thought that you should do a fecal blood test every year, or do a sigmoidoscopy, colonoscopy, and or a colonoscopy every 3 to 5 years. Now, if you have a normal colonoscopy, no polyps, they might put that to 10 years, depending on what your results are. But that should be started for normal population, again, at 50. Kind of continue. Men, kind of the same thing. Only thing we recommend that young men start at testicular self-exam, and then every year starting at age 20 having a physical exam, and again with the colorectal. We don't have any stopping guidelines for that, so that's always kind of controversial. But sometimes it goes by if a life expectation is 5 years or greater to continue. I'm going to hand off to Hope. We're going to be available for questions after her talk. And again, we have those sample test questions for you to take home.
All right, good morning, everyone. So I'm going to take it from here and focus more on kind of one of the risk factors that Kathy illustrated as far as family history. Just a little bit of background for myself. I'm a genetic counselor, as Heather kind of gave my background here. I've been around for a while, not as long as other people, but kind of the point of my talk is to review the basics of inherited disease, describe how genetics relates to cancer, talk about 6 specific cancer syndromes, and kind of discuss certain red flag indicators for even referring a person for genetic counseling evaluation, and then different options for genetic testing. And you guys have the handouts too, so I don't expect you to remember everything, but some important information to look back on. So Genetics 101, I can boil down your sophomore year of high school biology or genetics class in college pretty easily here. So every human has cells, obviously. Every cell has a nucleus, and the nucleus, with the exception of red blood cells. In the nucleus are chromosomes, and chromosomes are constructed from about 20,000 genes. The genes are made of DNA. So the ACGT chemical basis creates a very specific spelling for every single gene that we have. So we all have 20,000 genes. if you ever hear a person say that they have the breast cancer gene, well, we all have the gene. The question is whether a person has a mutation in a gene that could lead to an increased risk for something. So all cancer is genetic, but not all cancer is hereditary. So meaning that cancer or the overdevelopment of abnormal cells happens because of abnormalities in the genes of those cells, but majority of the time, probably 95% or more of the time, those are abnormalities in the genes that are just acquired over the person's lifetime. It's quite uncommon, probably only about 5 to 10% of cases, that a person will have a mutation in a gene that they inherit from a parent and then is present in every single cell of their body to put them at a higher risk. So this picture just kind of illustrates it. With the sporadic cancer, so again, 95% of cancers out there, a person starts off in life with 2 normal copies of a gene. And for every gene that we have, we get 1 copy from mom, 1 copy from dad. So all 20,000 genes, we have 2 copies. And what can happen over time, especially when a person may be at higher risk, depending on their lifestyle or things, say in a skin cell, the person's a sun worshiper, and he's on handicap. So at some point in life, maybe in their 20s, and just 1 cell in the skin, they acquire a mutation. But that particular cell still has a normal copy of the gene. So it's still going about and doing what that gene is supposed to be doing, which in the case of cancer genes is actually helping to prevent cancer from happening or controlling the growth of cells. So that happens at one point, and no problem, that's a normal gene. But maybe a number of years later, they continue their bad habits, and they get a mutation in the other copy of that gene in just that 1 cell. And so that's now when this particular cell doesn't have any control and might start to grow out of control and then develop severe cancer, which is essentially defined as a group of abnormal cells growing out of control. So that's kind of how all cancer happens, basically, or the majority of sporadic cancer. Other causes for these spontaneous mutations is age. Probably the #1 leading risk factor for cancer is just biologic aging. Cells aren't quite working as well as they should, and so they develop mutations a little more readily. To contrast that, hereditary cancer is different in that starting off from the genes that a person gets, so one from mom, one from dad, in a particular gene, maybe a gene that's supposed to normally prevent cancer from happening, they already have 1 copy that has a mutation. And that's in every single cell of their body. So they're already kind of 1 step closer to developing a cancer because of that gene inherited. But that doesn't mean they're automatically going to get a cancer. But if through the course of life they acquire a mutation in the other copy of that gene for whatever reason, then that they don't have a backup in that case, and that's when a cancer can happen. So typically, as far as white plagues, we'll see a cancer happening often earlier in life, often several decades before we typically expect that cancer. We might see multiple people in the family having cancers at younger ages. So those get to be some red flags that I'll kind of talk about in different hereditary syndromes here. Majority of hereditary cancer is considered autosomal dominant, so meaning that a parent, if they have a mutation, so in this case, we're looking at his genes here, there's 1 normal copy of the gene, 1 copy that has a mutation. This person, when he has children, it's a male in this case, it could be a female, it's a 50-50 chance of whether he passes on the mutation. And it's a 50-50 chance for every child he has. So in this case, they have 2 boys, 2 girls. 1 of the boys gets the mutation, 1 not, 1 girl doesn't, 1 girl does. Now, that doesn't automatically mean that they're going to develop a cancer, it means that they're at a great risk. So the actual presentation, or what we see on the outside, may not be that everyone who has a gene mutation develops cancer, but the inheritance of the mutation is an autosomal dominant type of pattern. So again, 50% chance of passing mutation in each child. Gene mutation equals increased susceptibility. Causes of cancer, we've gone over this a bit already. Sporadic cancer, meaning typically that there's probably just one case in a family or maybe a couple of cases, but much more related to other risk factors that Kathy had mentioned: age, gender, lifestyle, environmental. That accounts for probably 60 to 75%. In some families, we see a little bit more of a incidence of cancer than we might typically attribute to sporadic. So familial, maybe about 15 to 20%. And then maybe a family where, typically it's still more weighted on the sporadic risk factors, but there may be some unidentified genetic contribution to that. Other familial factors that may play, or risk factors that could play into this, could be shared environment, shared lifestyle. If you think of you and your siblings or you and your parents, you grew up with this group of people for 18, 20 years, you're probably going to have similar lifestyle habits, maybe end up living in the same area, and other kind of exposures play into that. Hereditary, which I'm more going to focus on, is only about 5 to 10% of the cause for all cancer, and that's directly caused by a genetic predisposition, so then inheriting that mutation from a parent. So 6 hereditary cancer syndromes, I'll keep an eye on my time here, that I want to hit on kind of fall into 2 categories. First are some related to predominantly increased risk for breast cancer. So we have BRCA1 and 2, or hereditary breast and ovarian cancer syndrome, which probably a lot of people have heard or are familiar with. 2 other ones that people often are not very familiar with, however, are Li-Fraumeni syndrome and Cowden syndrome. I'll link to each of those. The other kind of category as far as common hereditary cancer is colon cancer syndromes. The leading frequency of those is CISH syndrome, also called hereditary non-polyposis colorectal cancer. Some of you have heard, or HNPCC. Lynch syndrome is just easier to say. Another one is familial adenomatosis polyposis, or FAP. And the third is mute YH associated polyposis, or MNP. So breast cancer first. As far as red flags go, kind of hit on some of these things. Basically, younger than average age of onset, before age 50, kind of captures the premenopausal crowd of people. If a person has triple negative breast cancer, so ER, PR, HER2 are negative. Ovarian cancer at any age in the family, because hereditary breast and ovarian can live together. Males at breast cancer is a risk factor. It's quite rare for males to get breast cancer, but more common if it's hereditary. If a person individually has multiple primaries, maybe breast, later another breast, a new primary, breast and ovaries. There's pancreatic cancer at any age in the family. There's a couple of genes for pancreatic cancer could be a slightly higher risk. Ashkenazi Jewish ancestry, or Eastern European ancestry, Polish, Eastern Russia, or Western Russia kind of origin. If there's a relative who has maybe done genetic testing and they know that there's a specific gene mutation in their family, and you've got to remember that both sides of the family count. I'm talking about breast and ovarian cancer. It's very easy to think of the women in the family, like it's on mom's side. But as far as genes go, they don't discriminate for male or female. So a genetic risk can come from the dad's side of the family, even though dad himself isn't going to have ovarian cancer. It's a very low risk for breast. So breast cancer patterns. When we meet with a family and we're kind of going through this information, I think I get to it in this slide or this talk, but we spend a lot of time going through and asking a lot of very detailed questions about family history. So kind of back to the what can you do for your health, know your family history. Can you explain that? Sure, sure. So that's if a person has a breast cancer and through the pathology kind of workup, it's estrogen negative, progesterone negative, HER2 negative. There's been some studies indicating that maybe about 10% of the time a person with a triple negative profile, it's a greater chance they have a profile because they have a mutation in BRCA1 or 2. So just kind of that direct correlation, the little indicator. So thank you. We really spend a lot of time going through family history. Who's all in the family, how many siblings, nieces, nephews, parents, aunts, uncles, cousins, grandparents. Beyond that, if people know, and most people don't, but really trying to get a handle on who's all in the family, of those people, if anyone's had any cancer, what age they've had cancer, any kind of more specifics that may be known about their health history. And most people, when you ask about their family history, or if they say they're into genealogy, they're probably going to know date of birth, dates of death, when they got married, those kind of things, which is nice to know, but from kind of a health perspective, knowing the health history is actually very important in these cases. So as we go through a family history, if we see any of these kind of factors in a family, those are indicators to really think about pursuing genetic testing. So when we talk about genetic testing with individuals with any number of the red flags on the previous slide, we talk about different genes that can be involved. So again, overall, only about 5 to 10% of breast cancer is really hereditary. And this pie chart shows us what genes may be considered for individuals who are actually at higher risk. So this chart represents basically that if we presume that some kind of causative gene for this 5 to 10% hereditary pie, these are the genes that we know about at this time. So early 2015, we know that there's maybe 30 to 40 different genes that have been identified to have some role in breast cancer risk. So again, we all have the genes, but the person has a mutation that could put them at a greater risk. But probably 60% of the time, if we do testing, we're not going to find them cancer. Or there's probably a lot more genes out there, basically, that just haven't been discovered yet or aren't fully understood that might actually play some additional role in breast cancer development. So I'm always very careful to explain to people through testing that we can go this far with testing, but we can't test for every single gene that a person has in their body, nor do we even understand what all of our genes do. So we're still kind of growing in that understanding. I think a lot of people come in kind of expecting that, well, we'll do this gene test. If you have the gene, if you have a mutation, that means they're hereditary. If it's negative, then they're clear and normal. No, not necessarily, because it doesn't take away what's already happened in family history. So just a bit more about BRCA1 and 2. These two genes were discovered in the mid-90s. They account for the majority of hereditary breast and ovarian cancer that we know of. Again, we all have these genes, but if a person has a mutation that's characterized by early onset breast cancer, ovarian cancer, slightly increased risk for other cancers, prostate, male breast cancer, pancreatic cancer, the prevalence or how many people out there have a mutation, not exactly for sure, but anywhere between about 1 in 300 to 1 in 800 people, just in the general population. For a specific ethnic group, this Ashkenazi Jewish individuals, this is about 1 in 40 that a person will have a mutation. So that's why back on that red flag slide, just having a Jewish ancestry alone really is an indication to consider testing. Inheritance, again, autosomal dominant. De novo rate, which means that the chance that a person may have a new mutation in itself, yet not having inherited it from a parent, is thought to be exceptionally rare. And the genes are BRCA1 and 2. Again, there's other genes for breast cancer out there, but these are kind of the two main ones that we really look at. If a person, a female specifically, has a mutation in either BRCA1 or 2, her lifetime risk of breast cancer and ovarian cancer are the primary concerns, which are both elevated. So in this first chart here, it's kind of divvies it out by age. So breast cancer by age 50. General population risk for about 2%, about 1 in 50 women. With a gene mutation, that's up to 50%, or 1 in 2 women with a mutation. Breast cancer by age 70, general population risk about 8%. lifetime risk or lifetime considered, certainly later, about 87% lifetime risk. So a very high risk to develop cancer, but not 100%. So there are women out there who never develop cancer. If someone's already had a breast cancer with a mutation, they're at a significantly greater risk to have a second new primary cancer by age 70. General risk is about 11% for another primary. And then ovarian cancer, lifetime risk in the general population is less than 1%, about 1 in 70 is the, about 1 in 2%, but quite uncommon. With a gene mutation, I think that risk can be up to about 44%. So those are the two main areas of concern to be watching for women, and can alter then what sort of screening guidelines or prevention options we would talk about then, sort of like Kathy illustrated. So moving into another breast cancer hereditary syndrome, the Li-Fraumeni syndrome, which probably most of you have never heard of. This is a high-risk cancer syndrome that we typically see soft tissue carcinoma or sarcomas, osteosarcomas, premenopausal breast cancer, like pretty young breast cancer, 20s and 30s often. Specific types of brain tumors, adrenocortical carcinomas, leukemias, choroid plexus carcinomas. And specifically for some of those later ones, having that alone without even any of the other things is really a reason enough to do gene testing for that. The gene that's associated with that, actually skipping down here, is called TP53. It's kind of termed the guardian of the genome, so if you have something wrong with your TP53, you're in trouble. The overall prevalence of having a mutation in that gene is even more rare than BRCA1 and 2, about 1 in 5,000 to 1 in 20,000. Which is a pretty big range, but it actually is pretty rare. Inheritance, similar to BRCA1 and 2, autosomal dominant. So if the parent has a mutation, 50% chance they'll pass it on. Not a 100% chance a person will develop cancer, but pretty high. De novo rate, estimate about 7 to 20% based on some different studies that have been done. So with a family history of seeing really young cancers or some of the different types of things on that first point there, that would be an indication to consider testing for TP53. Overall risk, I forgot to have a slide up here, just kind of relative risks, sort of go in order of risk. So the more often the time we'll see certain types of bone cancers or osteosarcomas, certain types of connective tissue cancers, brain cancers. Breast isn't really high on the list, so we're probably not always going to see a really good breast cancer. We might often see other types of cancers at a young age. An overall lifetime risk of cancer, even at the age 60, is about 90%. So really high risk is something that happens. But at age 50, by the age of 30 years. So more of an emphasis on younger genetics or younger decades of life. Cowden syndrome is the third kind of main syndrome really regarding breast cancer risk. So in this type of condition, we see both cancer issues as well as skin issues that aren't necessarily cancerous. There's also not listed on this slide some kind of behavioral and learning disability issues that can go along with this, which are not at all cancer-related. So cancer-wise, things we typically see are breast cancer, thyroid, endometrial, colorectal cancer, renal cell carcinoma, skin cancer. Cutaneous or skin type of issues, trichomoniasis, which are a specific type of skin issue, often seen kind of in the mucus area of the mouth or even sometimes kind of around the eyes. Acropalmar plantar keratosis, so palms of hands, feet, getting these kind of, kind of tougher keratosis kind of areas. Papillomatosis lesions. So it's similar to the trichomoniasis thing, areas where there's just kind of extra little skin plates, essentially. Often, I don't think there's a picture there. A person who just looking at them, say, you know, a woman in her 50s, we've met a couple people with Cowan syndrome, just a lot of little kind of bumpy skin areas around their eyes, along their nose, kind of creases, areas of the face, among other areas of the body. Specific type of brain lesion, or mediduclos, I'm probably butchering that name, which is a very kind of rare type, and again, with having that alone is a reason to consider testing. Certain types of colon polyps. The other parts I mentioned about the learning issues, autism or kind of learning disabilities, lifelong, and macrocephaly, large head size. So sometimes, and actually this gene is even considered to be tested when a child with autism is having genetic workup. This gene is often tested. Prevalence, maybe 1 in 20,000, probably an underestimate though, because there's a lot of people running around with these kind of things that, you know, maybe it's just mild enough that they've never been picked up. And the de novo rate, or having a new mutation, is actually relatively high, with us up to almost 50%. I think in both cases, the families that we've met with, the individual women, they were the only person affected in their family. I mean, you look really hard at the family history, and there's no breast cancer, no thyroid, no endometrial, nothing at all. So probably a better chance it's going to be a brand new mutation than not. Again, the gene is PTEN. Overall risks, breast cancer, approximately 25 to 50% risk over lifetime, with the average being in the 40s. Thyroid, about 3 to 10%. That's kind of one of the hallmarks that there's a pretty good chance we're going to develop that. Endometrial, about 5 to 10%, and especially increased risk for uterine fibroids as the kind of precursor. Overall lifetime cancer risk about 40%. So that's something that we don't necessarily see even happening in families. And maybe it's only manifested by the skin issues, or by a large head, or by just kind of being a little bit slow. So it can have a lot of different kind of looks to it. Genetics of colon cancer, when we go through our detailed family history, if we see things like early onset colorectal cancer, so under age 50, colorectal cancer with multiple adenomas, so multiple polyps, this kind of a lot of stuff going on down there, 10 or more cumulative colorectal polyps, early onset endometrial cancer, this can run along with colorectal, or 2 or more Lynch syndrome related cancers, either in the individual or among close relatives. And those different Lynch syndrome cancers are in the star point. So colorectal, endometrial, gastric, ovarian, ureter, renal, pelvis, biliary tract, small bowel, pancreas, brain, spacious adenoma. There's a bunch of different things, and they're kind of listed basically in order of frequency. So when you get down to the renal, pelvis, and down from there, we're talking fairly uncommon now to see those type of things, but certainly much more of a consideration if we see someone with a young colorectal who had maybe a sister with endometrial or ovarian, and maybe a father that passed away at age 55 in colon. And that would be definitely a family to consider Lynch syndrome. So Lynch syndrome is really the most common hereditary colon cancer syndrome. Again, the different cancers that it's characterized. Prevalence, or how many people in general population may have a genetic risk for Lynch syndrome, about 1 in 660 to about 1 in 2,000. De novo rate, again, chance of having a patient, thought to be quite rare. There's 5 different genes that are have been identified that are associated with Lynch syndrome. They're called MLH1, MSH2, MSH6, PMS2, and EpCAM. With the 2 more common ones in that group being MLH1 and MSH2. And if a mutation in one of those genes is found in an individual or in other family members, then again there's specific screening and prevention guidelines recommended for those. Overall, the cancer risks that we see for colorectal cancer up to about 82% lifetime risk, again the average being quite a bit younger than that individual. Even younger than what the typical starting age for doing a colonoscopy is. So it's not uncommon to see someone who maybe hasn't had their standard age 50 colonoscopy, yet they've had collected bleeding or something prior to that led them to go in. However, because of that younger age generated diagnosis, if a mutation is found in the family, if a person knows they have Lynch syndrome because of the gene condition, you want to start screening younger than age 50 because it can happen younger than that in this population. Endometrial cancer up to about 60% risk, average, a bit younger than average, average being kind of in the mid-60s, so 10 to 15 years younger than that. Gastric cancer up to maybe 13%, mid-50s being the average. Ovarian cancer about 12%, early 40s being the average. And the lifetime cancer risks actually depend upon which gene is involved. Generally speaking, MLH1 and MSH2 have higher risks for these cancers than a mutation in MSH6 or PMS2. So this one, if you depending on the gene, really directs how much of a risk there would be. Polyposis syndromes, kind of the other two under the colon cancer category, are FAP and MAP. Generally speaking, in these ones, the main cancer list that we see is colorectal cancer. We really don't see endometrial or ovarian or gastric, these other kind of things. But there's a really high chance, like nearly 100%, they're going to develop colorectal cancer. And if you went in there and did a colonoscopy, instead of just a couple polyps, you're going to see the things like cultivated polyps. So really, really high risk, often very young age, like not uncommon to see a colorectal cancer in the 20s or 30s with this condition. Autosomal dominant, you pass on the gene mutation from a parent. De novo rate, maybe 20 to 25%, so this can happen spontaneously. And there's two different genes with these. For FAP, the gene is APC. It's like alphabet soup when you get to genetics. The MUT-YH associated polyposis, or MAP, the gene is MUT-YH. The difference with the MAP condition is that that gene is actually autosomal recessive. So you have to get a mutation from both mom and dad to have the risk. So just a nice little picture here about polyposis. So the normal colon, nice and smooth with an FAP. I mean, it's just, yeah. So that would be a case where actually screening and prevention would be more emphasis on prevention, like get the colonoscopy out, or get the colon out of there because it's going to develop something. So how does someone know if they have a hereditary cancer syndrome? Like we talked about before, you know, family history, looking at the red flags, and indication actually do testing. For actual genetic testing, this is kind of blown up over the last couple of years, hasn't it, Kathy? That, you know, traditionally BRCA1 and 2 were really the only two genes for breast cancer, either Lynch syndrome or APC for colon cancer. But since maybe about 2012, there's been a lot of emphasis on kind of looking at as many genes as we can related to these cancers. So a lot of the times anymore, if we see someone with a strong family history for hereditary breast, we're not going to look at just BRCA1 and 2. We'll look at maybe a 7-gene panel, which would include some of the kind of higher risk genes. Actually includes the TP53 for leaf and the PTEN for Cowden. Or in some cases, we may look at even a larger panel. And so it's kind of gotten, it's gotten a lot more confusing, not only in sort of what tests may be recommended in certain cases, but also what the results might be, and then what to tell the person about what they should be doing given that result. Cost, genetic testing is universally pretty expensive, several $1,000s. Probably the number one question we have for people is my insurance going to cover it? Sometimes. Maybe not all of it is kind of the boiled down answer for that. For the gene panels, meaning looking at, you know, dozens of different genes, there's some pros and cons. You know, a lot of people kind of say, well, just let's look at as much as we can. Yeah, I just want to know if there's anything there. And I think we're in an information age. People generally want to know if there's something there. And I kind of caution people that the pros, it's more cost effective. We're looking at more genes for essentially kind of the same cost. We get more information. It's good for people who meet criteria, and actually there's demonstrated reason to be looking at these genes. But on the other side, it's harder to convince insurance companies to cover these large panels when maybe they're really not even at that high risk to start with. There's a higher VUS rate. VUS stands for variance of uncertain significance. And this has been the biggest difficulty, I see a nod of the head there, that this is when we find a mutation in a gene, but the lab is kind of like, I don't know what it means. And so basically that means that it's a mutation in a gene. We know it's something different than what should normally be there. But there's just not enough data out there, be it from the lab's perspective or even from different publicly shared databases, to say whether that specific mutation in that gene does lead to a higher risk, or maybe it's just a benign change that we happen to find because we were looking at it. So, that's difficult then trying to not only explain it to a patient, but to say, well, we found this, but we're not going to change anything about what we do, or, basically forget that even happened. Let's go back and still treat you at higher risk because you have this family history. Eventually information will catch up, and we'll find out more about what these things mean, but it's been a tricky couple of years in the meantime trying to sort all this out. I won't go through all this, but just kind of gets a rundown for the higher risk genes. Possible results, positive result indicates that mutation is found that does for sure lead to a higher cancer risk. Negative result, those particular genes that are tested are normal. They're there, we expect them to be there, but there's no changes. The thing we have to caution people about that is that even if we get a negative result, that doesn't totally mean that there's no hereditary gene out there. It just means that everything is normal from what we looked at. And we can't look at all of our genes. So the uncertain variant or inconclusive, again, like I just talked about. And you can read through some of these things later on. But generally speaking, kind of the reason to do testing is to determine what a person should be doing going forward, how much screening to be doing, whether you should do prevention, those kind of things. Overall takeaways from this part of the talk, most cancer is not hereditary in a small number. There's certain hereditary conditions that are more rated on breast and colon, and there's genetic testing available. Because genetic testing is quite complex and has gotten a lot more complex in the last couple of years, we really try to emphasize our kind of meeting with the people up front on really going through all this information, explaining all these things, basically just like my talk here, up front so the person realizes kind of what the possible outcomes could be. Now there's a lot of doctors out there, OBs are being marketed, family practice doctors are being marketed by labs, that they can do all the genetic testing, and I think for certain individuals they're very capable of doing that, but a lot of times we've been getting calls then after the fact, this has had testing, now they got some weirdo result, we don't know what it means, can you meet with me about this? Kind of just an education standpoint of things, but we're here, of course, if there's ever a need to meet with people about these things. So, all right. Yes.
So is the Lynch syndrome, you got like possibly 5 different things going on that are wrapped together? Do people have variances in more than one gene at a time?
It's possible to have a variant in more than one gene, but generally speaking, if a mutation were found, typically it's just in one gene. It's kind of like the overall chance of having a mutation is this small, so if you have multiple, it's like even smaller. But it can happen that there's multiple genes going on. Typically for a given family, though, if there's a higher kind of history that's indicative of Lynch syndrome, most of the time it will be explained by just one individual gene. Yeah.
What would you suggest as far as genetic testing of someone having no idea of their?
We see that a lot of people that are adopted or estranged from their families or anything. In those cases, we really go on what their personal history has been. I mean, if they're a 40-year-old woman that just got diagnosed with breast cancer, that would be a reason to be doing testing based on her individual history. If maybe she knows what her ethnic background is, maybe she knows that she's of Jewish origin, that would be a reason. We just go on as much information as we have available. So, other questions? Thank you, guys. Okay, our next presenter here will be Kim Bland. She's a certified family nurse practitioner who's been in the oncology research department with Nebraska Methodist Hospital since 2000, with an additional inpatient oncology responsibility since 2012. Kim is actively involved in cancer screening programs, community education, cancer prevention, and volunteerism. Kim is responsible for the FACT stem cell accreditation at the hospital and is quality management supervisor of the program. Please welcome Kim. Please.
So they give you a great overview that's going to kind of intertwine with what my slideshow. So my slides are more just reference. So I'm just going to hit on the kind of the pearls or the pieces that I see with different things that may be key to you to look for if somebody has a certain type of cancer or something. So I'm, you know, the general things are going to be true of all cancers. With needing to know different things. So it's impossible in the time frame to go through everything, but I'm just going to try and hit on the little pieces and cues of things that may be helpful about specifics. So this is 9% of your test. The genetics I covered pretty well. I have a few slides in there, but a few also interspersed throughout. So part of those they already covered. But mostly I'm going to talk about basics of cancer immunology and then a section on protocols, and then the last bit will be devoted to the different cancer types. And so cancer in general, you know, when you think about cancer, what is it? What does it mean? And really, to be a diagnostic cancer, you just have to have cells that grow out of control. They lose their normal boundaries. In your normal cells, when they grow, they stop when they hit another one, but cancer doesn't. And so that's a piece of the cancer definition, and then also that they have the ability to metastasize, so they can travel through your body and go elsewhere, which normal cells don't. So those are kind of the highlights of it. When you're trying to figure out what type of a cancer it is, if you get a question about one, you can kind of look at the word, and that'll give you some indication. So if it's you know, carcinoma, that means it's skin and tissues, the carcin. If it's leukemia, then, you know, blood and hematology. So that'll give you some indication of what type. They're named after either the cell type or the cancer type. So it could be like colon cancer, breast cancer, those are pretty easy. Or it could be like melanoma, which is named after a melanocyte. So just going to look at the word if you're not sure. There's over 100 different types of cancer. So if you get a question about a certain type and you're like, I don't know what that even is, try and break down the word, and that will usually help you figure it out as well. And so it's thought that cancer arises in different stages. And so initiation is the first stage. And what initiation is just means that you've had some exposure to something that alters your DNA. So it's like a hit on one of your DNAs. And so it's initiating the process that could become cancer. Usually is a point where the body decides it's something that affects your DNA, but can your body fix it, repair it? Or if your body doesn't know what to do with it, or if it's had too many of those, then it may turn into a mutation of what we call a cancer cell. So that's the initiation, is that first time that you're with something. And then the next step is promotion. And so promotion is the step where it's maybe a second time where it's something that affects the DNA, and so it's promoting the cell growth, and it's starting to take over what your body normally could stop. Maybe at this point, if it's had a number of different insults, maybe your body can stop the normals, keep the normal cell growth, and so now it's turning into promoting abnormal cell growth. And so there's just more damage to that DNA than there was previously. And then progression is just, as you would think the name is, it just means that things are progressing, the cells are becoming more aggressive and getting past where they normally were, and could even be at a point where they're wanting to invade the different tissues around it. And what they do, how they do that is they build new blood vessels. And you'll find cancer is pretty smart. It figures out what the body normally does and works around it. So these new growths of cells will find ways to build little blood vessels, and that's called neovascularization. And that's how it gets more nutrients, because the normal supply isn't enough to feed all these new cells. So it builds more tracts to get nutrients there. And so that's why you get some of them are really vascular. So some of our drugs now are working towards that. So it's called angiogenesis, is when the blood vessels get to the new tumor and try and provide it with nutrients. And so I'm going to throw out some different questions, so I hope you guys will be interested in participating. But some of our drugs now work against the building of new blood vessels, and it's called anti-angiogenic. Any ideas what drug is the most common one for that we use? Very good. Bevacizumab, Avastin. Exactly. So the idea behind that drug is to hit the blood vessels, cut them off so they don't grow. Exactly. So as we go through, we'll talk about some of the different drugs and how they work so that you can see logically why certain drugs are used with certain diseases. The important part to know is that this isn't like a one-year process. To get through all these different stages, it usually takes several decades, and so it's not like it's, yesterday I had a sunburn, now I have melanoma. It takes normally decades. So if you get oncology magazines at all, there's a ton of them out there that are free, and they just give you updates on things. But there was actually an article in one not too long ago about the father of carcinogenesis research just passed away. So he started doing research on this in the early 60s. So yeah, kind of the background between some of the things that you read about and see is kind of interesting. This is just a cartoon about a multi-stage model of carcinogenesis. And so again, as I talk about the different steps that you go through, you can see the different points that are, DNA, is it repaired or not with initiation? If it isn't, then you can go on to promotion. But you'll hear different words like proto-oncogenes, and the proto-oncogenes is what's normally in our body that allows cell growth, but it knows when to stop. If you have just an oncogene, then that's when the cells no longer know when to stop. And so some of the words, if you're reading anything on cancer research articles, they'll talk about oncogenes. And so oncogenes are just when cells no longer normal and they don't know when to stop growing and they can't repair anymore. And then there's also something called tumor suppressor genes. So they're kind of on the other side, that they tell the body when to quit growing. And so cancer can be caused by either oncogenes or tumor suppressor genes. And so some of the different markers that Hope was talking about that they can find, do you have an aberration in like the RAS gene, which we know works with colon cancer. So if you have a RAS mutation, there's a drug that works, against some of those. So that's where this comes into play. So a RAS is a oncogene. So if it's normal functioning, or it can be abnormal, so you can have abnormal RAS mutation, which then could lead to colon cancer. So these things all fit together. It's just a matter of kind of learning the terminology and what they mean and how they fit in. Now, she had a little different portrayal of this, but in the early 70s, there was a gentleman named Knudsen who built off of a 1953 theorist. And the idea behind this is just to say, again, that it takes a hit on both sides of the DNA to get cancer. If you have none or you have one, then you're not really at risk of getting cancer until you have two. So that's why it's called the two hit. And so the point is, if you have already one, because you got it from your mom or your dad, it takes less insults. And so you could get cancer earlier because you've already got one on board, if you will. And so sometimes it could even take, I'm not saying that every time you get, say, a chemical exposure that could cause cancer is absolutely going to cause cancer. It may not. Your body may well fight it off. But it's just saying if you're inherited, it's going to probably appear sooner in life, earlier, than if it's not. And it's thought there could be between 5 and 10 different times that same exact gene would have to be hit before it would become a variant. So it takes a lot, actually. It really does. But the key is just it's not an overnight thing when people get cancer. But because of that, inherited takes less insults. If you see somebody younger with cancer, that's why we think more hereditary, because it doesn't take as many to get there. Okay, so they went over a lot of this carcinogenesis. I'm not going to repeat a lot, but this is just kind of interesting. It started in the late 18th century, and there was a doctor back then in London who found chimney sweeps had a lot of lung cancer. And so he got to thinking, well, why is the population getting this? And so that's kind of where it started, and it's built upon to say, what does cause cancer? So these are just kind of a list of different things that we know may affect the cancer. And interestingly enough, it takes about 1 billion of our cells before you can actually detect it by any scan or palpation or anything. And in order for a tumor to be potentially lethal, it has to be about has to be about a kilogram, so 2 pounds. So that's a lot of cells. So it takes a long time to get to that point. And then just a few more there. Some of the others that aren't listed, now they're looking at obesity and sedentary lifestyle. You guys hear that a lot too. So what's the difference between neoplasm and a tumor? Is there a difference? Actually, same. So you can hear it called. And a neoplasm or a tumor can be cancerous or benign. It just means there's an abnormal growth of cells. If you hear the word cancer, that means malignant. So you'll sometimes hear those words like they're interchangeable, like tumor and cancer, but technically tumor, neoplasm are either malignant or benign, and the cancer is what is malignant. So quick question, and I give you the answer below it, but just some different terminology that you may hear. How come cancer cells live longer? So as you can see, initiations on it, we talked about that. Apoptosis is where that normal cell, when you hit another cell, the cell should die. That's normal. Apoptosis just means that cells don't die like they're supposed to, and they resist that dying part. So just some different words that you may hear. Cancer immunology, again, kind of a big section of your textbook if you're reading, but it just means like, can your immune system, can we use the immune system, or what does it do naturally to fight off cancer cells? And so it's becoming more and more of a focus in cancer treatment. So what we're looking at with immunology is those cells that you learned in basic micro, so like dendritic cells and CD4 cells and B cells. And so just kind of go back and look at how those work in the immune system and what's your initial response. And so what do cytokines do? Because some of our drugs initiate cytokines. And so those are just some things that you might just want to kind of brush up on and see if you can refresh your memory on those. But the immune response is really of particular interest with cancer treatment because we're now looking at, the IL-2s, the high-dose IL-2s, and vaccines, trying to rev that body up to fight the cancer itself. All those normal things you see when you have immune function, when you get the flu, that's what the vaccines and such typically do, inflammation, feel great, tiredness. But the thought is if we can train our body to fight cancer cells, it's a longer remission, if you will, longer, maybe even a cure, than if we just treat with drugs to kind of tone down what the cancer cells are doing. So immune therapy, biologic therapy, those sorts of things. And then another thing to kind of keep in mind is, what's the different barriers, what's our normal immune response. So we have the natural barriers, which is like our skin, mucosa, the GI system where you have that flora in your gut that should help. That's why when people are on long-term antibiotics and they lose that normal flora, they're at risk for Exactly. So it's a protective thing so that infections don't get in there. Fever and inflammation and all kinds of different things that help us keep those toxins out so they don't get in and make us sick. Acquired is when your body has already had exposure to something. So when you get a vaccine for measles, and then your body kind of is like, oh yeah, I know what that is if you get exposed to it. So right away, it mounts that particular immunity towards that antigen. So acquired is something that you've had exposure to, and then your body knows what it is to fight it off. So there's a couple different ways that immune plays into our health, but it definitely has a part into carcinogenesis as well, as we'll get into some of the other cancers later. Okay, which of the following interactive functions of the immune system help with the red cells, help develop cells? So hematopoiesis, that's another word that you'll hear, especially if you're working in the hematol. But hematopoiesis is just keeping everything in balance and in check. So it's keeping things regulated, making cells when they know they need to be made, and then stopping production. So that's kind of the background. We'll get into the diseases where we'll pull some of that in a little further too. Now we're going to move to kind of the next topic, which is research trials. And so research studies have been around a long time. They've had some good press, they've had some bad press, but truly that's the only way we've gotten where we are with cancer treatment and the drugs that we have. Somebody has to be willing to go through the research studies. And so we have a research department here at Methodist, which has really done a lot of work in the cancer arena. So it's a great thing, and the patients are really protected and watched carefully. So I'm just going to go through a little bit about what research is. So when you hear clinical trial and research, a lot of people think they're the same thing. There's just a slight variance. So a clinical trial is something that involves human patients that you're doing something with. And so that would be what we're doing with our oncology trials, or if there's an asthma trial or a C. diff trial, it's using humans to test a device or a drug. The research, so clinical trials are research, but research aren't necessarily clinical trials, because you could do research on observations. So, you know, I want to see how many people run that red light. You're not really doing it with somebody, but it's something that you're counting. You can have research in business, looking at spreadsheets to see, you know, past functions and what it means for the future. It's not something that involves drugs or actively with people. So, you know, we say we do research because it is that, but not all research is trials, clinical trials, because they don't actually involve working with patients. So, and again, the trials are important because that's how we get where we are with our treatments and know what we do with side effects and, you know, maximum tolerated doses, that sort of thing. And so why would somebody benefit? Well, we're hoping because it's going to help them with their cancer treatment, but also because a lot of the patients feel like they want to do something to help others in the family. They want to contribute to science, and, you know, sometimes there's minimal risk, or they may have no other options. And so there's a lot of reasons why people participate. The different phases of trial. So phase 1, you'll see these different words. Phase 1 is really the first time the drug is introduced into a human. So what they do is what they call different, I'm drawing a blank. They have 3 patients that they treat with the drug, see what the side effects are. If they do okay at that dose, then they enroll 3 more. And then they enroll 3 more. And they try and go up on the dose to see. So the phase 1, they say, is not a treatment for the patient, but it's a test of the drug. So we have to be sure and tell patients that. You know, phase 1s we typically think are last resort trials, but if they want to do it because there's no other options, then they may. But really it's a test of the drug. So we want to see what side effects the drugs have, how much can they tolerate before whatever reason they can't tolerate it anymore. And so that's when they know to back down on the dose. But it finds the dose, and it's, you know, 12 people, 15 people, very small, trying to figure out, does that drug work? What are the side effects? What dose can we give? Very initial. If the phase 1s are promising, it goes to a phase 2. Phase 2s are typically everybody gets that drug. You may get standard with that drug, or you may just get that drug. But it's trying to find now, is it initially look like it's helpful to that patient? What are the side effects with a bigger population? So phase 2 is to be 50 patients, maybe a little bigger. But you're just trying to really see if the phase 1 was accurate with what you found with a very small number going to a bigger population. And usually, again, on a phase 2, there's no randomization, if you will. And so if 2 looks promising, then it goes to a phase 3. So phase 3s are when you have this, what we call treatment arm or randomization arm, stratification, but there's usually at least 2 different regimens a patient can get. So they have, say carbotaxol plus this, carbotaxol plus that. And so it could be, now they've kind of tried to skew down the numbers because research monies are short, but phase 3s could be 500 to 1,000 people. There used to be in the old days, it used to be 3,000, 4,000, 5,000. The trials for the tamoxifen had 60,000 people and 50,000 people. We just don't do those anymore because the money's not there. So that's a phase 3. We want to see if their standard care or the treatment is better. And so it's a bigger population, trying to find more side effects, more data if it works. And then normally if the phase 3 is positive and there's parameters that the person who writes the study has to say, it has to meet this criteria to be successful. So some maybe has to be less toxic than the current treatment. Some say it has to be 10% better than the current treatment. They have to set that out in the beginning. And so if it meets that parameter, then they'll take it to the FDA to say, look, we met our thing. The FDA looks through it to see if there's any problems. Was it truly a scientific one? Was there any bias? Were the patients representative of the general population? Did you do all men? Then you can't, treat women because we have no data on women. So it can be approved. A drug could be approved on a phase 3 trial. The phase 4 is what it, and so the phase 4 is, we use, we use a drug for, it's like Cialis, I guess, is a good example. They found that Cialis work for one indication, and then another thing that they found is, maybe it causes hair growth in men. So the post-marketing as part of their side effects. So then post-marketing, they want to do a trial to say, how does that help people grow their hair? And so you'll see it called different names based on the use. And so there's one for bisphosphonate that we use for cancer treatment. They normally get every 3 months. And the same drug is used in a primary care office. They use it once a year. Has a different name. So they thought to keep osteoporosis away in people that are high risk, we'll just rename it. They had to do additional studies. That would be a phase 4. The other thing you can use a phase 4 is, say when Herceptin was first approved, and they want to see generally how are people using it, what side effects. So they do a registry. And so anybody who's on Herceptin can be in it, and they just want to get tons and tons of data of real-life experience using the drug. So it's just getting more data, the phase 4s. Compassionate use or expanded access are very similar, and what that means is a drug looks very promising, or maybe what we call orphan drug. So orphan drugs are 2,000 people or less diagnosed with something a year, and there'll never be enough people to go through all the phases to do a trial. So what the company does, they put it out in an EAP, expanded access, or compassionate use. So if you enroll to this, the company essentially gives you the drug, the physician, to use as you want. Sometimes they'll have a little bit of a protocol, but then they just want the data back. How does the patient tolerate it? What did they do? How did the disease do? That sort of thing. And so it's a way to get to a drug earlier. Often the companies will do it expecting FDA approval, but it might be 3 years before their turn to get reviewed. So they'll often do this to get more data while they're waiting for the FDA. But it's a really nice option for patients to get a drug. Yeah.
So if you, because especially looking at the resources, when they get to maybe phase 3, are they still tracking phase 1 and 2 patients?
They do. Unfortunately, the phase 1, normally on our trials, they follow people until they pass away, typically. So phase 1 patients are kind of last resort when we're talking about cancer trials. So they typically will go on and unfortunately don't live, a few months. But most of our phase 2, phase 3, we follow them until patients pass away. Now, so on our breast trials, we follow those forever because fortunately they live a long time. But I don't know currently because I haven't been involved as tightly, but there are some ladies who are following 20-some years yet because breast cancer is kind of known for late recurrences, 10 years out or after, and they get recurrences. So it looks great the first 5-10 years, but you don't want to call it good because we know they come back late. So most patients we follow until life. Now there's a few studies when they decide they have enough information and they think it's truly representative. Then they'll send a notice to sites that are doing that study to say, you know what, we have enough data, you can stop following them. But most patients we do follow until they pass away, and then when they do, they have a form that you submit and say, what did they pass away from? Did they have a second cancer? Did they get a malignancy? So they're trying to track, was it the drug, was it a side effect, was it the disease? So they keep pretty tight reins on their data. Okay, so some other words you might hear with research. The IRB is the Institutional Review Board, and if you're going to do studies at a site, you have to have your IRB. So like ours, Methodist has their own IRB. They meet once a month, and you can use a central IRB. Now is the way a lot of places are going. So there's 3 or 4 throughout the U.S. that are central IRBs, meaning you can send all your stuff to them. They take care of everything and send you back. Local IRBs like ours tend to stay because they want to make sure our patients, we want to know what's going on with them. We want to know what's being conducted there for research. If something bad would happen to our patients on a research study, we want to know before it gets in the newspaper. And we want to make sure the consent is fair and honest that we're telling the patients about. And so the IRB has to be at least 5 members. You have a chair, should have a backup or a co-chair. They are to have different backgrounds, and one has to be a lay or community member. And so ours actually has about 9 to 10 people on it. We have an attorney sit in on to make sure we're doing the right things legally. If there's HIPAA questions of that, she kind of chimes in on that. But we have physicians, we've had dietitians, we have social workers, we have had somebody from the college, you name it, any background, anybody who's interested and willing to read a lot of research and paper, and then they give us feedback about the informed consent. And so the informed consent is a document that when we review the patient, it used to be 10, 15 years ago, 8, 10 pages. And now because of all the legal, it's sometimes 30 and 40 pages, which you can understand that. So it goes through why we're doing the study, what their options are, the risks and benefits, side effects of the drugs, what happens if we get new information, what is their cost, what tests are we, or things are we providing that they don't have to pay for, just a lot of legal stuff. So when we meet with a patient, we go through it with them and then give it to them to read. We also give them a bunch of information about what are trials and ethics of trials and just a whole packet of information. And then ideally, they take it home, read it, we follow up and say, did you have any questions about it? Do you want to participate? And then if they do, we bring it back in, go through it again, have them sign it. And so informed consent is that document, which is legal. We have to keep it forever. And then it also goes all the way throughout their treatment. So say you don't necessarily have to review it every time, but sometimes there's updates to say, oh, now there's a new side effect of this medication. Are you still interested in participating? Or it might just be updating them on, how the study's doing, if you have anything like that. But the idea is just to keep them informed all the way throughout their participation. Sometimes we'll get people that are a few years out after, and they say, hey, that study was on. Let me find out with that. Or maybe it was a blinded study. Nobody knows what one drug. And so they are, Dr. Silverberg's notorious, calls up and says, I need to know. Sometimes they tell us, sometimes they don't. So we do have a lot of ongoing relationships with our patients because they're on for usually quite a while. The biggest thing about research is voluntary. They don't have to participate if they decide not to. They get standard of care, whatever they and their physician decides. But our physicians are not going to offer them the trial nor call research if they don't feel like it's an appropriate treatment. And so with clinical trials in oncology, we do use placebos, but they always at least get standard of care. So as I mentioned before, it might be lung cancer, carbotaxel they'll get, which is standard, and then we're adding a drug or adding a placebo. Because if you know you're not on something, or you know you are, sometimes you have side effects, if you know you are on. So they always at least get standard of care. And then they're followed really closely, and so everybody on it gets their CT scans at the same intervals. They all get the same blood tests at certain intervals. So it's very rigid. So they're getting standardized by what everybody agrees with the guidelines should be done. So as you know, some oncologists do bone marrows and follow. Some don't do any. If they're on a research study, they have to do what the protocol says based on standardized guidelines. So, but our nurses do a great job of following patients, answering questions and such. So it's quite a process. Just some different terms that are related to trials. The informed consent we talked about. Blinded just means patient doesn't know. Double-blinded means the patient doesn't know. We don't know. Sponsor obviously would know, but when they send you medication, it's got a number on it, and they say dispense this bottle number. So that's how we know the right patient's getting that bottle. And then randomization is just which treatment arm do you get. You put their information in, and then the computer says give them treatment A. So patients have to be okay with whichever they get. Sometimes when people say, well, I'll do it if I get that arm, it's like, can't do that. So stratification is when the study, are you a smoker? Splits them up that way. Are you female, male? Splits you up that way. So it has what type of histology. So it tries to make sure that both treatment arms have very similar populations, but that's called stratification when they use those separate criteria to move them. Placebo is just like a sugar pill, inactive. We use it because we want to make sure that patients aren't biased thinking, I have an extra pill, I need to have more side effects. So standard of care is what they would get even if they're not on a trial. And so standard of care things patients pay for, their insurance pays for, just as if they're on standard treatment. So anybody with lung cancer is going to have CT scans, so that goes through the insurance. What trials paid for is anything not standard. So when we were doing the initial Herceptin trials, the study wanted a MUG or an echo, and physicians have a preference. I like MUGs, I like echoes. But whichever one they chose, the study wanted the other one at the same exact time. So they paid for that second one. So because they wanted to see if there was a difference in the results between MUGs and echoes. And so the second heart test, the study paid for. So that otherwise everything standard of care is built to insurance. And then a subject is a patient, but once they're enrolled on a trial, they're called a subject. So just a technical term there. And so the really important part, this just reflects that it's really important to make sure that you put the right patient on the trial, that they're truly eligible. We have a page or two of things they have to meet and things they can't meet to go on a trial. So if it says their hemoglobin has to be 9 and they're 8-9, they can't go on trial. If they need to have a scan within a month and they've had it in a month and a day, they either have to repeat the scan or they can't go on trial, or else you get false results. So really skews it. Any questions about trials? Yeah.
When you were talking about insurance being
certain things.
Is it the drug companies that pay for the trial? Who pays for the trial?
It depends. The government is what they call NCI, or the National Cancer Institute backs a lot of them, and then the government has a pot of money that they use, to say we have to spend this much on trials. And I don't think that money in the government's changed in like 20 years, so it's gone. And then now we're having to rely more on pharmaceutical studies, their money to back. So we might have what would normally be what we call cooperative group, meaning through the government, that pharmaceuticals have to say, I'm going to give you this much money, but here's what I need out in return. Because otherwise they wouldn't be able to do the trial. There's just not enough money to do them anymore. And so they help with writing the consent, making the budgets, that sort of thing. And then anything that's determined outside standard of care, they have to pay for. It's really rare for a government-supported study to pay for anything. It's really rare. So in the, I guess, fortunate part in oncology, they can order about anything, and we can say it's somewhat standard of care. So like they might want LDHs as a potential biomarker, and in oncology, we use LDHs. Some we don't use them. I mean, I don't know if anybody knows the answer, but it's not outside the realm that somebody would order it. And so if there was a trial that ordered an LDH, we could consider it standard of care, because some physicians might order it, some may not. Another example is like CT scans on our GYN patients. So when they're done with treatment, the study says we want them every 3 months or every 6 months, because we want to know what's going on. Now, some in that office never do a scan after, unless there's symptoms. If they're on the trial, they have to do it, and it's considered standard of care because by the guidelines, that's how often you should do them. Even if ours don't do them that often, that's what the guidelines say you should do and follow. So the pharmaceuticals will sometimes also pay patients travel to get here for a trial, but sometimes help with mileage and hotel. So yeah, RRB has a rule that we can't pay patients stipends. So if you come in for every visit, I'll give you $25 because they feel it's close. Some other places you go may pay your airfare to get there and your hotel and everything because they want patients on trial. But RRB is very conservative and they feel that's coercive, so we can't. So you'll see different things at different places, but it's really a matter of reading over the protocol, figuring out what it is or isn't standard. There was a study, I'm trying to remember what it was for, maybe lung cancer. a lot of the new drugs, the biggest concern is what's it do to your heart. And they wanted like 15 EKGs, and they were going to pay me $20 for an EKG. And so I had an ongoing discussion with the radiation oncologist at the time. There's no way we could afford it, because you get $2,000 is what you get for a cooperative group payment typically, and that's for all your time enrolling until the patient passes away. And we probably spend 10 to 12 hours getting a patient on study, not to mention how many times they come in for a visit, the paperwork after. And so you have to really look at that. There's no way we could do certain studies if we don't get that reimbursement. So as you know, enough one's $20. Not anymore. Yeah.
Where would you say most of the trials, where's the majority of patients, or what amount of trials? Like phase 1, are they all?
Oh, we started, kind of our research department here got revamped in about 2000, and everything was a phase 3 because they're the safest and they're all government supported. And so since then we've really worked to get phase 2 because that's earlier introduction, and the docs always want the newest and greatest thing, which you aren't going to get in a phase 3. So a lot of ours now are phase 2 because it lets the physician use that drug. They get used to they give you guidelines in the study to say, if your hemoglobin's this, hold the drug. If your white count's this, go ahead and give the drug. Or, they're having this much diarrhea, dose reduced by 25%. So it gives the physicians a great chance to get used to using that drug. Then when it comes out, they're like, hey, I know this drug, don't have to learn it. Phase 1s we do, but they're rare because they're riskier, and there's a lot of extra oversight IRB wants to have to make sure that it truly is a good trial since it's testing the drug. But we wanted to offer some because otherwise we have to send patients away, and we hate doing that. So, if they're melanoma, we might send them to John Wayne. If they're carcinoid, we might send them to Iowa City. So we wanted to get some of those studies here for them. So we have a few phase 1s, and compassionate use and EAP are less options now. They just aren't allowing that as much as they used to. So I would say here phase 2 and 3 are our biggest ones. The 2 is the newer. We don't quite know all the side effects yet, but that's one our physicians like. Patients are more comfortable with a phase 3 because you have more data. But they get randomized, which they don't always like. So it's kind of a trade-off.
And how do you guys communicate with the hospital as to what a trial is paying for and what a patient's paying for?
So when they're in the hospital, it's because they're sick. And
like when they go for a CT or like an echo. And
right.
They want
so,
that.
Oh.
How does registration?
Yeah, so we have a form that we made, and so when we know a patient's going to get a CT or a heart test or something, the nurse fills out the form, and it's kind of on the sound sheet, and we work with the office who's scheduling, and so when they schedule it, they should tell whoever this is paid for by research. So they make a note. We give the patient a copy of that sheet, and then on the day they come in for that test, we bring another one to that department, so they match them up. And then research has a client bill, so those tests go on my client bill, and then the rest go on their bill. So it might take a little longer to check in because you have to check in twice, but then that way those go on the client bill, and then we get those paid, and the patient doesn't have to. And that's how it works. Sometimes there's little overs. We've had a few legacy patients on my bill, so had to move those up. So this question just refers to if a patient says, I don't know if I want to keep being a research trial. The point here is just always their option, no matter what. It's never right to make them feel like they're going to harm anything. It's always what's best for them. And we have to just keep reiterating that. Okay, on to cancer. So the diagnosis of cancer, a lot of these things as we go through the different diseases you'll see are very similar. So just as you're reviewing it for the test, things that they may ask, incidence, how do you screen for them, how do you stage, what testing would you do before? Tumor markers are a big thing. Pathology has a molecular lab now. They hired a physician that we share with the Med Center focused strictly on tumor markers. And so if you have, testicular cancer, what tumor marker might you see ordered? So typically it's either HCG, AFP, some of those. If you have colon cancer, what are they going to check for that? CEA, CA19-9. So when you see what's ordered, it's thought that gives us an idea of how the cancer is doing. So tumor markers are huge. And then personalized treatment, when I talk about then and now, and I even mean then, 10 years ago, we originally thought if you have colon cancer, it's the same colon cancer. You get the same drugs, you get the same treatment no matter what, and it's the same expectancy. So it wasn't really personalized at all. And so what we do now, we do all these markers, and we have all these new drugs that hit targets, And we try and focus it so that maybe two people have a breast cancer, but they have different markers. So this person gets different drugs, they get different treatment, they get surgery, this one may not. And so it's really based on that individual's cancer and their tumor. So when someone comes in and says, I have AML, and I talk to this person on the hall, and they have AML, and they say they're, not going to make it another month, but they were diagnosed the same time. You have to remind patients, how are they presenting? Do they have a lot more symptoms when they present it, which is typically a worse prognosis? What were their markers? I mean, and they don't know that. They think what they have and what somebody else has, no matter what, is the same. And so they are completely different diseases between patients based on histology and how big was it and different things. So it's really important to say, now we look at cancer based on each individual, not a breast cancer per se. And I think it'll eventually get to the point where you don't say, we say, oh, it's a lung cancer patient. We might say that patient has an EGFR cancer because you're going to treat that cancer based on that marker that you want to hit. And so I think eventually we'll move away from calling cancers by the disease site. But, say you have somebody with a RAS mutation, no matter where that cancer is in your body, you're going to use that same drug. So I think it's going to move a little more generic based on markers once we get more of them figured out. And so biomarkers is a big thing. This is, again, just a cartoon about targeted therapy, and this is a simple cartoon. This is a simple one. Usually it's a whole circle with targets all the way around. But the point here is all those little initials are different markers that drug companies and the government with their studies are looking into to say, how can we hit, mTOR inhibitors? Timsirolimus, hits that one. And the PI3K, we have a drug for that, EGFR, Tarceva, the RAS mutation, cetuximab, HER2 is on there somewhere, that's Herceptin. And so VEGF, we have a lot of VEGF inhibitors. And so the idea is that we're trying to find not just with our standard chemo, where you're going to hit good cells, bad cells, and you get all the side effects people get from chemo, but we want to just make it very focused to hit that particular marker so you don't get all the side effects of standard chemo. And so when you see those drugs and people come in and they're on these weird little drugs, can you bring it from home? It's one of these. And they're very expensive, very expensive. I think the most expensive one I heard of was an oral drug that was $13,000 a month. So they're very expensive. Most, I would say, probably average between $5,000 and $7,000. So you don't want to lose that bottle. There's a bill in front of Congress right now to have chemopariety is what it's called. And it's been in front of them for a couple years. But, when they come to the office to get chemotherapy, generally it's covered pretty well. When you go to your pharmacy and pick up a bottle of Tarceva, they may say, well, your copay on $7,000 is 20%, just like any other drug. Well, who could afford that? So they're trying to get this chemopariety bill passed in front of the legislature to say it needs to be treated the same as IV chemo. It's the same treatment for the disease. We're moving to oral so that patients wouldn't have that hardship of, I need treatment. That's what's going to be my best treatment, because if they have an actual target, sometimes we can just use that oral treatment, forget all the chemo. There are fewer side effects. I can stay at home, take it at home, come in once a month. But if it's prohibitive, the oral, and we can't get sample or, some drug companies provide help, if we can't get that, then the patient may have to get IV just because they can't afford the oral, and IV may not be the best. So hopefully that will pass this year. It's the insurance companies are fighting it, as you can imagine, because they don't want to have to pay that much difference. But that's the idea behind the targeted therapy, is just simply, all these different things. Small molecules are like oral, Tarceva, you name it, any of the pills. But the small molecule is called because it can actually cross through that membrane. So it can go inside and catch some of those targets. And then you have like monoclonal antibodies, which are human-made in a lab, but they focus on different things. And so they are like your Avastin. So different targets, Herceptin, trastuzumab, that's another antibody. And so they hit on the outside of the cell because they can't make it through. So very interesting if you want to kind of read. I have to hear it about 10 or 15 different times before it starts a little bit to make sense. It's really complicated, but it's neat. I think it's a cool idea. So TNM staging, again, you probably know, but the TNM is used for pretty much all the different diseases. And so the T is for tumor, how big is it, how far does it grow into others. The N is, do you have any nodes that are positive or negative? and then M is for metastasis. And so it helps us decide what the treatment should be. It helps us decide if, if it's already metastasized, maybe surgery is not appropriate. And so you'll see T and M. And the tumor registry we have here at Methodist has sheets for all the different diseases the physicians have to fill out, showing what the T and M is, and then they enter that into a tumor registry and follow the patients. But it's a nice thing to help us predict prognosis and treatment for patients. So that is TNM. Okay, breast cancer. So part of this Hope went over already, and Kathy about risk factors. So your number one risk factor is female, advancing age. The younger you are, if you have a male, okay, some pros. If you have a male who's diagnosed with breast cancer, they should automatically get a genetic referral. So it doesn't matter how old. Typically they're 60s, 70s, but it is so rare to have a male breast cancer. They should have genetics regardless. But males can have, mastectomies and chemo and everything just as women. The screening test that we talked about, so just kind of review when should you get mammograms, when do you do self-breast exams. The new thing is, I forget what Emmanuel has or Allegiant, but heat. Our radiologists here don't believe in that yet, so we're holding off on getting that thermal imaging or whatever they call it. There's the CAD reader, which is an extra reader that after the physician looks at it, they run it through this program and they see if they find any patterns that look abnormal and they'll point it out to the radiologist to go back and look. That's been a great thing. And all of our mammograms here are CAD read now. And then some people that are really high risk, you may see an MRI ordered. And so MRIs should always be used with a mammogram. You should never do an MRI without, because you need both to have it make sense. So a lot of people, if you're high risk, so say your mom and a sister had cancer and you really want to know early, some people will do a mammogram at 6 months, and then the other 6 months they'll do an MRI. Now the tricky part is MRIs pick up a lot of stray things, so you may get a lot of workup and never have it be anything. So it depends on your anxiety, and then if you're okay with having biopsies if we don't know what it is. So ultrasound's another. If you have a palpable mass, so often just ultrasound it, and then by the look on the ultrasound, they can tell if it looks like it's cancerous or not. So staging for breast cancer, there's actually a stage 0. It's called in situ. So you might have seen DCIS, LCIS, and there's debate, do you call stage 0 cancer? Hypothetically, it should not be able to develop into cancer, but they always remove it if people get radiated. So either way you want to call it. But it just shows you, the more advanced or stage 1. So if you have a stage 1 or DCIS, typically they'll do surgery and then and radiation. And then, for 2, they can maybe add surgery, radiation, and then depending on your risk factors, they may add hormone treatment in there, so letrozole, Femara, toxin, something like that. And that's a risk reducing, so it's to prevent cancer on the other side. And so then as you get further along, when you're at stage 4, unless there's a reason, you're going to do surgery because I'm out of the bag already. So you would do radiation for painful areas. If they have bone nets or something like that, you may do radiation, but your systemic treatment is your mainstay for metastatic disease. So, and then there's a couple different types. So most of it's called ductal, but there's a couple different types of breast cancer that, I don't know, they may ask a specific question about the inflammatory. Typically has a little worse prognosis, but it's usually presents as quite red, painful, may have induration, but there's not like a ideal mass. It's more general. And then the other type that you may hear is called Paget's, and it's what we call puta orange, and it looks like kind of an orange peel. It's around the nipple, and that's really got a bad prognosis. So there's different types. Inflammatory typically is more aggressive. Paget's is hard because people get it and they think, dry skin, and they let it go. So it is a hard one to tell. So why do we do hormone assays? Any idea why we do ER, PR? What do you think that affects? So when they look at the tumor under the microscope, they'll do all kinds of tests, and they'll say, you're ER positive, PR negative. So, yep. So if somebody is hormone receptor negative, meaning ER, PR, they would be both negative. Then if you give somebody tamoxifen or that, would have no effect. Yep. So if they're one or the other, typically ER, or it could be PR, or both. If either are positive, then you would use the tamoxifen, relaxafen, those sorts of things. If they're both negative, it would have no effect on them, so we don't give it. And then the other one, it's not really hormone, but the other thing we check for every time is HER2. And HER2 is typically more aggressive cancer. So again, 10 years ago, that was a bad thing because it was more aggressive. We didn't have anything to treat it with. Now we have Herceptin that hits that HER2 target, and people that are treated with Herceptin for a year actually have a little better outcome than if you're HER negative. Long term, we don't quite know yet what that means. So again, it's hitting the right target. So, but when they do the pathology, they always report ERPR HER2. So usually now they're reporting infinitive curve, mitotic rate, Ki67. So they're adding a few other markers on there now that I don't know that we quite know what to do with them, but they're able to do them in the lab, and sometimes they think they're prognostic as well. Which racial group has highest breast cancer? African American. And the reason we think that is because we think as a general population, they may not be getting their standardized screening as well as the rest of the population. So it's not necessarily mean that it's more aggressive. They're just usually caught later because they may not be doing their screening as per guidelines. All right, moving on to bladder cancer. Oh, one more thing on breast cancer I gotta tell you. There's a couple movies out. I know it sounds weird, but about breast cancer. They're very good. So Decoding Annie Parker is about Dr. Mary Claire King and her work in discovering the BRCA1, and it took like 10, 15 years to discover it. Very good. It talks about all these families and how they figured out the gene, and everybody thought she was crazy, and then how she finally found the BRCA1. So, and I think that was in 1990, I want to say, she finally discovered that. That is called Decoding Annie Parker, and that was just last year. 2 years ago, sorry, 2013. And then the other one is called Living Proof, and it has Harry Connick Jr., which isn't bad, but it talks about how Herceptin came about. And Herceptin is a Genentech product, and its initial trials were negative, but this, Dennis Slayman is the doctor who discovered it, and he really believed in the product and it would make such a difference. So when Genentech quit financing, and they were going to shut the lab down, he found a couple very wealthy people that had breast cancer in the family who supported that research and finally got it so that Herceptin was approved. And now, of course, it's made Genentech millions and millions of dollars. But anyway, that one's very good too. And that was like a 2008 movie. So 1996 when Herceptin finally was found to be effective. But very good. There's just interesting learning about those in a different way. All right, so moving on to bladder cancer. So again, when you look at these different cancers, just kind of think, what are the common treatments used? Where do they go to? If you ever get a question on the test, where do things go to? Usually bone and lung are pretty safe answers. Liver is another safe answer if you don't know. And then probably after that, brain, liver are backups. But almost everything will go to the bone. So just something to keep in mind if you have to have a multiple choice. Bladder cancer is more common in men, 4 to 1, and primary histology is transitional cell. So that's what all the research is based off, is transitional cell. And so if somebody has a different histology, we don't quite know exactly how it's going to respond. But typical treatment is surgery and then maybe chemo, radiation, depending on, you know, other symptoms the patient may be having. So, and then prostate cancer, you know, there's always debate about who gets screened, how often do you get screened. And the guidelines, you know, pretty much say if you're at risk, you should be screened. Otherwise, do it in moderation because PSAs can be misleading. Some people get really anxious about them. And if you want everything done at a 0.1 or 0.2 rise, then that's going to be tricky. So prostate cancer is staged by the Gleason score, is what they call it. And so if you have a Gleason less than 7, it's considered low risk. I would say the majority of what we see are Gleason 7, which would be intermediate. And there's a good chance for a cure with that. And then if it's over 7, so it goes to 10. So if you have 8, 9, or 10, then it's high risk and you have higher rate of relapse. That Gleason score is what we use. And that's right in the path report. So, and then the other treatment you'll see used for this is hormone blocking. So they use that anti-androgens. So side effects can sometimes be impotence and different things like that. So sometimes people aren't crazy about some of those things with hormones changing in the body. So renal cell, the important thing with renal cell is often when somebody's diagnosed with renal cell, they'll have these other, what we call paraneoplastic syndrome, so maybe hypocalcemia, or they get some neuropathy, we're not sure, but that's very common with renal cell. Cigarette smoking, again, is associated with, and tired meals. The tricky part about renal cell, there's no screening test. So usually presenting signs are hematuria, something like that. There's no way to catch it early, if you will. But it's still pretty treatable. And so survival, if you have early stage, is about 70%. If you catch it when it's metastatic, it goes down to about 10%. So at the initial sign of hematuria or palpable mass is a later sign, but regardless, as soon as you get in with this, definitely changes your outcomes. Often they'll do nephrectomy surgery is kind of the typical treatment for this, and then they add on other things as needed. Chemotherapy for renal cells not typically as effective. So that's why our patients get put in the hospital. They can have the option of interferon over a year, which feel like you have the flu for a year, or you can go in the hospital and get our lovely high-dose IL-2, which is top treatment. But about usually 10 to 15% on the high-dose IL-2 may respond as a cure, and there's no other treatment right now that will cure people, and that's why we do the high-dose IL-2. But it's a tough treatment. And that, again, is working with your immune system. So it goes back to that. So bladder cancer, most frequent in women. All right, so this is a question about the screening. So right now they're saying, at age 50, or if you're higher risk, do annual screenings with a digital rectal exam, PSAs, but you just always have to talk to people about what those PSA results mean. So, and then the other key point, true about mammograms as well, if somebody's at the point where, and you never know, but you don't think they have a life expectancy of 10 years, then we typically will kind of stop those routine screenings. The thing about prostate cancer is they think, people they've done autopsies and that have passed away, and people that are 90 or older, almost everyone has had some prostate cancer. So they're saying maybe it's just a normal part of aging. So when do we really need to start treating it? That's the debate.
What would cause their PSA to be falsely elevated?
There's some herbal things that will raise it. Some, I don't want to say manipulation, but that can. Depending on, if they've had sex the night before or something, that will raise your PSA sometimes. So there's different things that herbals are really tricky. There's one called saw palmetto that a lot of people like, but it makes your result look low. So you could have a PSA of 5, 7, and if on saw palmetto, it may read 1. And so it's really tricky when people want herbals. We try and, when they come in for cancer care, we evaluate what they're on and see if there's any kind of known things that may throw results, but yeah, it's just a little tricky. And then, then there's a debate about how soon do you treat things. We know there's a lot of prostate cancers we do surgery and treat that may never, it's kind of slower growing, may never even need treating. So, all right, lung cancer. 2 types of lung cancer. Anybody know? Very good. So the importance between small cell and not small cell is because small cell is very aggressive. So you ask someone in the hospital diagnosed with small cell, you can pretty much bet they're going to start chemo while they're in the hospital. It's really aggressive. And it likes to respond, like you give chemo, it melts away. Great response, but it always comes back, So that's the tricky part. Non-small cell, they're staged differently too. So small cell, you either have limited, which means essentially it can be encompassed in a radiation field in the chest, or extensive, meaning it's outside. So that's the difference, limited or extensive. And then with non-small cell, it's stage 1 through 4. So, and again, stage 4 is always worse with any of these, and metastasis is what stage 4 means. So if you have a non-small cell, typically they'll have a surgery and be in the hospital, and then they let them go home and kind of get a week or so maybe where they recover, and then they'll go in the office, talk about treatment, prognosis, start treatment in the office. You have more time with non-small cell. And again, common sites, bone, and brain is another one. And small cell especially likes to go to the brain. And so if patients are willing, and I don't know, Maria, how many patients take you up on this, if patients are willing, they'll do what we call prophylactic cranial irradiation, or PCI. You have a lot of takers on that?
We did in the past, and it seemed like we have as many now.
Okay. We had a study in the past. I don't know, maybe that had part of it. We did. But the tricky part is, we try and radiate. Now, that sounds weird, but we try and radiate the whole brain, keep those cancer cells away before we even know they have brain mets. On the other side, when you radiate a brain, it kind of sometimes causes people to not think quite as clearly. So that's the debate. It's tricky, but small cell likes to go to the brain. So, and then if they don't do PCI, or if they do it and they get brain mets, then, you know, they would treat brain mets like they normally would anyway. But the idea behind PCI or prophylactic is to try and stop it before it starts, or catch it before we can see it. So it's a tricky one. 85% is non-small cell, so fortunately most of it's the slower growing type. Smoking, again, causes about 90% of lung cancer, they say. So with non-small cell, you'll see treatment, any doublet, and so it doesn't matter, take your pick, all of them the same. Taxol, cisplatin, doesn't matter, pick any two chemo drugs, they'll work it out the same. And with research, now we're trying to add some targeted drugs plus minus. So we did a study with carbotaxol plus minus or erlotinib, didn't make any difference, and I think people actually had a little worse outcome. So now they typically do chemo. When you're done with the chemo, 4 or 6 cycles, so about 6 months, then they'll put them on the erlotinib, or put them on erlotinib without the chemo. So trying to figure out that ordering is sometimes tricky. And then should people quit smoking? Never hurts. You know, their lungs will do better through surgery and breathing and things, hopefully, if they're not. But we allow people for this and head and neck cancer that still smoke. So, and then non-small cell, or sorry, small cell typical treatment is cisplatin. They usually add like an etoposide in there. It likes those topoisomerase drugs for small cell. And then why is lung cancer more difficult to treat? So typically there's not an early screening for it. We do have here called the ILCAP, which is the International Lung Screening Program. So if there's like 5 or 6 criteria, you meet one of those, you can get a CT at a discounted rate to look for lung cancers, hopefully catch it early. Debate about that. And then this is the other one that Kathy had talked about, meso. So meso is kind of tricky. It's not technically a lung cancer. It can be lung, can also be peritoneum. And it's treated just a little bit differently. We usually treat it with like Adriamycin, IFA, somewhere in there. But it's a little trickier because it's hard to get rid of. It can be in your pleura, it can be in your pericardium. Lungs very common, but it can be generally anywhere in your trunk area. Surgery, chemo doesn't always help. Most studies show there's no improvement in survival. We do it because we want to do something, so people usually look at chemo. Sometimes they get radiation, and they thought that may help. Average survival is about 14 months with meso, no matter what you do.
Is it always linked to some chemical exposure?
Typically. We don't always know, but it could be. You know, we think it's pretty rare, but typically we think it's either like people that worked in the service on jet airplanes, or, you know, the airplanes that went over and they're around cleaning the airplanes up, and some of those chemicals, that's one they think. And then asbestos is another. But typically they think that there is some kind of a chemical exposure. That's typically what is. So it's a tough one. 5-year survival for overall is only 15%. So it's not great. We haven't made a ton of improvements with lung cancer, unfortunately. And then here's why should we consider a trial? Because nothing else we're trying is working. So maybe a trial with a new drug will. I don't know. It's tough. GI cancers. Okay, so GI cancers are anywhere from your mouth to your anus. Again, different ones. Look at staging, tumor markers, what treatment, side effects. And again, mets. You're safe with lung, bone, brain, adrenal. Always a good choice if you have that question. And treatment for GI cancers in general, sometimes you'll say, get a PAC report back and you have a patient and they're like, I don't know how to treat him because it says unknown primary. And then the doctor will say, what does it look like? GI? Does it look like lung? Yeah, it looks more like GI. So for lung we use like the platins. For GI we use more of a 5-FU. So that's why they even just want a hint of what it looks like, because your treatments are so different. And if it's truly unknown primary, we would use like a carbotaxol, very generic. But if it looks more like a GI, then you want to get some 5-FU in there because that will help. So that's why even if you don't know that it looks more like a GI, they'll use a different regimen. So kind of a tricky one. Anything 5-FU, there's usually 5-FU with 1 or 2 others. But that is a standard treatment. So which one is not associated with increased risk of colon cancer? Some of the chronic colon, those people that come in with Crohn's disease, depends on the number of insults, how far they let it get before they get treatment for it, are associated with, I think, cancer. IBS, because it's an earlier one, they don't feel it's far enough along typically to cause cancer. So if it gets into some of those others that are more chronic and they come in repeatedly for surgeries and resections, then there's thought that that probably is a more higher risk for colon cancer. And again, the colon cancers treated with 5FU, rectal cancers. If you're looking from the anus up, at what point is a rectal cancer turned into a colon cancer? Any idea? 12 centimeters. So 12 centimeters below is rectal, above it's colon. I don't know how to pick that, but that's the number. So if you read the report, I've seen some, it'll say colon cancer is at 13 centimeters, and somebody write, oh, we have rectal cancer. And then I've seen one of the oncologists say, is that 13? Or, you know, whichever one. It's not this, it's the other one, you know. So they are very set on that number. But, yep, 12 centimeters is where the cutoff is. And then another, screening. So your FLDTs, your digirectals, colonoscopies, those are typical screenings. And markers are your CEA, KRAS, those sorts of things. So there's another type of cancer in the colon that you don't see very often. It's small bowel. Pretty rare. I think I've only seen a couple. There's no approved treatment for small bowel cancer. Nothing's FDA approved. So it's kind of a menagerie. The oncologist picks and chooses what they think is best, but there's no approved treatment. So
They would do surgery.
it depends. I mean, I say no, they generally don't. They usually treat with chemo. Even if they did surgery, they'd want to do something adjuvantly. So, you know, there's no chemo drugs approved for small bowel. So it's that rare. It's tricky. Esophageal, as you know, can be really a challenge as well. They have a lot of swallowing and such. Survival, average overall survival. So when I say survival, if you hear the word survival, it's how many people are alive at 5 years. So when you hear the word survival, they're talking about 5 years. Esophageal, 7%. Not great. So some people can have surgery, some people don't. You know, it just depends. Typically, it's squamous cells more related to smoking. And adeno can be Barrett's, where you have that stricture or reflux, that type of thing. They think is more risk factors for that. Gastric, okay, most common pathology for gastric is adeno. And H. pylori, they think, is a risk factor and some good. The gastric cancer, they think, can be related to diets, the smoked foods. People are typically over 40. The tricky part about gastric is, you know, the symptoms are bloating or gas or reflux, and so a lot of people are like, I just treat that myself. By the time it's severe enough to come in, it's well advanced. So that's the tricky part about gastric. Dumping syndrome, I don't know if you've heard of that or not, but that's like your GI system's kind of messed up and it just dumps a bunch of food at once, and patients are very uncomfortable. So frequent small meals is gastroparesis, in other words. So, all right, pancreatic. So pancreatic cancer is not a good one either. CA19-9 is one we watched for that. Typically, ideally, if we can, they treat it with surgery, chemoradiation, maybe surgery. So it's just a tricky one. You know, with treatment, survival is anywhere between 6 months and 15 months. It's not great no matter what you do. Usually people opt not for treatment. It's about 3 to 4 months. So there is one type called neuroendocrine. That's the type that Steve Jobs had, very slow growing. If you do surgery and take it out, those people can potentially be cured. If you didn't want to have surgery, when you wanted it, it's too late. So liver cancer, primary sign of liver cancer is weight loss, decreased appetite, that sort of thing. 5-year survival for this, if it's local, is about 30%. So, yeah, 63 years old. Itching and jaundice are usually presenting signs. Sometimes they can do surgery again. If they need chemo, it's usually a 5FU-based regimen. Reproductive ovarian cancer, common size of disease. Typically in the peritoneum, the metastatic is more what it can get into peritoneal studying. It doesn't always go outside of like the other cancer, so it's kind of whatever is nearby it wants to invade. It can go into the bowel, so you see all these people come back at end of life, bowel obstructions, what do you do with that? So because it's real close to where the primary is. It is surgically staged, so although we follow markers, sometimes they're accurate or not, with a CA125, you'll see people with many of these GYN cancers maybe have a surgery by their primary GYN, but not a GYN oncologist. And the GYN doc will go into a history and he's like, oh, there's more in here than I thought. Does what he needs to do, sends the patient here, and then the GYN oncologist here has to go back in, open them up and get all those lymph nodes and do a proper staging. About 30% of the people they have to upstage because it wasn't done properly there. So it's unfortunate because people have to have 2 surgeries, but in order to know how to treat them, you need that staging, and that's all surgical. So, yeah, so GYN officer are great. If you ever need cancer surgery, reproductive, make sure you go to a GYN to do it. And sometimes you'll hear the word cytoreductive, and so that means, it's too big, we can't get it all. But sometimes if you do cytoreductive surgery, it gives more room in there, maybe relieves symptoms, gives them a better idea of tissue diagnoses, may help the patient with the quality of life. But cytoreductive is just taking out what we can get, knowing you're not going to get it all, to help symptoms or get more tumor for the lab to look at. So. And then for cervical cancer, GYN cancer is, by the way, staged by FIGO, F-I-G-O, so a different staging system, but it's still, 1 through 3, 4. And so the other parts we look at with histology is grading. And so a tumor, if it's a grade 1, that means it's pretty well differentiated. It can still do part of its normal job. If it gets to a grade 3, that means it's called anaplastic or poorly differentiated. So those cells that are sitting there aren't able to do any part of their job. So if you have a grade 1, you're catching it pretty early. You still have some function, but if you have a grade 3, it's pretty much all tumor that's not able to do any work it's supposed to do the original. So grading is another important factor we look at with all these cancers. So those path reports are 5 or 6 pages long. They're very important. So you're whittling through them to figure out what they all mean. Endometrial cancer, again, very similar. This one, the presenting symptom, postmenopausal woman comes in with bleeding. Endometrial is proven otherwise. So again, surgically staged, AFPs, HCG, some of those markers, we look at with CA-125s. PAPs are, a good way of finding them, and then these are the ones you'll see, biopsies or cone biopsies or DNCs, that sort of thing, to try and work them up. Average age is 50 to 70, but postmenopausal bleeding is a key for endometrial, if you get that question. Testicular is a younger population. Average age is 15 to 35. Very good cure rate. Dr. Larry Einhorn had a huge oncology group actually made this protocol. It's fat-based, but if you catch it early enough and you treat them, it has about a 90-95% cure rate. So very good. Yeah, very good cure rate. In fact, I don't even know if we really have much for testicular trials anymore because that is such a great treatment. The important part about this, or any of those cancers, if you have somebody younger, think about sperm banking, because once we give chemo, it may or may not affect their ability to have kids. And so sperm banking, I was curious, it costs about $1,500 initially to do it, and then there's a $50 storage fee a month, which I hadn't really thought about. It's kind of expensive, but a month, $50 a month storage fee. Yeah. So any of these, cancers, just think about sexuality and maintaining function. Some people go through treatment and still have their menses, some don't after the first chemo. You just don't know, but if they want to have kids, they need to tell the physician. Sometimes they can spare an ovary or something if they would think they want to, or sperm banking, those sorts of things. So you just have to keep that in mind with any of these. Okay, skin cancer. So a few different types of skin cancer. The basal cell are the ones that are kind of a ulcerated look to them, the edges, and they're pretty slow growing. They hardly ever metastasize. Squamous cells are the ones that look kind of shiny, and they just don't heal. It's like, I've had this in my ear and it just won't heal, squamous cell. Typically, you can go to a derm and they'll take those off. And squamous cells, if you let it go long enough, can metastasize. Now, melanoma, where does it start and where does it spread? Who knows? It can be anywhere. Melanoma is tricky. Definitely likes to metastasize. The important part is if you think that it's a cancer and you want to get it properly staged, this just shows the skin and where they are. But if you want to get staged skin cancer and sun, we talked about earlier, but primary staging, there we go. So if you want to get it staged, they do it by what's called a Breslin index. And if you go to a derm, sometimes they do what's called Mohs, and they take it off and look at it and keep shaving and try and get clear margins. You can't get a depth from that. So if somebody's had Mohs and now they have a melanoma and you want to see what stage they are, you have no idea, because you can only get a depth by an excisional biopsy. And so the Breslin is what we use for that, and it's very good about prognosis. So that's why we like the excisional. because that's the only way you can truly get a proper staging. There's something else called the Clark's that is part of it, but it's more like, is it in the fat, is it in the dermis? It used to be the thing to follow, but now that we have a Breslow, it's just like that added note, if you will. So Clark's staging, Breslow index. The Breslow is really what we want for skin cancers. Okay, head and neck cancers. So head and neck cancers, the biggest thing about head and neck cancers that makes them so tricky is because they're so devastating. They affect your airway, they affect your appearance that everybody sees. And so typical things we associate with are smoking and drinking. Survival rates depend on where they are. The thyroid cancer, if you're diagnosed with that, can be up to 90%, but if you have an oral cancer, maybe 50, 60%. There's like, I don't know, 50, 60 different sites just in your head and neck you can have cancer. So that's why you need a head and neck specialist. Common sites, again, lung, extension of where they are two common areas. Typical chemo is this flat, unless they can't tolerate for some reason. This flat affects your kidneys. You have lots of fluids. It can also cause hearing damage. So if somebody's already lost their hearing, you wouldn't miss this flat typically. And then HPV, as I talked about, that's a risk factor for some of the head and neck cancers, oral cancers. HPV associated cancers are thought to have a better outcome. So we're starting to check HPV more. And I know one of the oncologists, if somebody's diagnosed with that, will try and get the patient to go in and get their Gardasil to try and knock that HPV down. Male, female, doesn't matter. But insurance won't pay for it. I think it's like $400 or $500 for the series. So some people will, some people won't. So again, surgery is a mainstay treatment. First line, chemo, with without radiation. A lot of times the chemo is like a sensitizer, so they get radiation, we give them something just so the radiation works better. But surgery is a good mainstay with diagnosis, and then often they'll do radiation after. Of course, the more modalities you add surgery, chemo, radiation, the sicker the people get. So these aren't exaggerated by any means, but these are typical head and neck, and you can see why they're so devastating. So, yeah. Okay, brain tumors. Brain tumor staging is by WHO, WHO grading. And so you have 1 through 4 for brain tumors. And again, 1 is the best, and they're usually benign, so like ganglioma, something like that. The grade 2s are what we call gliomas. There can be any mixture of words with like glioma at the end. And the grade 3s usually have a word called anaplastic in front of it, so anaplastic and whatever. So as you go up, each one's a little worse. And then grade 4 is what we call glioblastoma multiforme, or GBM. And so the tricky part about the stage 4s, often that's how people come in. They've had a seizure, they've lost their balance, whatever it is. But the GBMs are tricky because they're brain tumors, but they're not like you think of a tumor. They like finger in, and there's no way really to get it all out. So GBMs are tough treatments, just because you can't ever get it. So, and then the other side of brain tumors, other than a primary, of course, is the metastatic. So say you have lung cancer in the brain met. So you have to, understand if it's primary or is on metastasis. You're treated just a little differently that way. So a lot of the treatments for primary brain tumors are chemo, Avastin use sometimes, and then of course radiation. And there's a number of different radiations that they can give. And sometimes if it's a brain met, they can do what's called gamma knife and do a radiation surgery, if you will, that way. But really important for any of these head and neck, neuro, to have all your disciplines involved, to get all your options up front, so you know where you're going and what your backup treatments are if your initial ones don't work. There's brain tumors in kids. It's the #1 tumor in kids, brain tumors. So a little different type of tumors in kids, but those are called like medulloblastoma or rhabdo, things like that. And so this is a picture of where brain tumors can be. So like astrocytoma, I'll go up in there. That would be, I didn't see GBM listed on here, but that's typically where your stage 4 should be, right in that same area. And then as you remember, the brain has different functions wherever you're in it. So when they go into surgery and do it to take it out, you have to think what part of the brain was affected. Maybe it's their speech area, maybe it was their coordination area. So they're trying to take the tumor out, but maybe it's going to affect the normal area of the brain. So when somebody has surgery and maybe have a deficit after, it could be because that part of their brain was affected by the surgery. So each part of the brain has its own functioning, and so that has part of their post-recovery. Spinal cord tumors can be primary as well. Some are benign, so you could have like a meningioma, neurofibroma. Those are schwannoma. Those are more benign. Or you can have a primary in the spinal column. The one in cancer we're more familiar with is the cord compression with the spinal cord net. And so those are really hard because once that cancer gets in the bone and starts chipping away, making the bone real fragile, it gets into the spinal column, and then it's just as if you've had a spinal injury. So, say you've had a motorcycle accident and your spine's broken. That's the same thing cancer does. So you get paralysis, you get numbness, loss of bowel bladder. With any of these, if they don't get taken care of and they impinge on that spinal cord, because once that cord's damaged, it takes a while for that to come back if it ever. And you then get seizures. So it's really very tricky. But so many places metastasize. Lung cancer, breast cancer, lymphomas. So if somebody has back pain or loss of healing, you always want to make sure you rule out spinal. All right, heme. Sorry, we're at our time. We've got about 10 more left, I think.
That's fine, because mine is
Okay. So leukemia, these are the tough ones, I think, because there's such a different way of thinking. So leukemia is disorder of your white blood cells and your lymphatic tissues, and everything, as you know, is made in your bone marrow. And so when something goes wrong there, it affects what happens to the rest of your body. And so there's lots of different types of leukemias. And so when someone comes in, they'll classify it, so it might be like an ALL or AML or a CLL or a CML, and all those have just a little different prognoses. And most of the ALL, or acute lymphocytic, is in kids. So if you see ALL, think kids. And that's true of a lot of these diseases. If it's on the test site, if some 15-year-old comes in and they have a leukemia, what do you think it probably is? ALL. So age, tumor markers, all kind of help you try and figure out what disease it is. So like CML, the one thing you often will hear with CML is, Philadelphia chromosome positive or B-cell. So certain words can typically go with certain diseases. So if you see there B-cell able, it's probably CML. So it's just hard to remember all those because there's so many. And then the differences are just little differences as far as outcomes and how you treat them. And the CML, the chronic myelogenous, now we have a great drug called Gleevec that is oral, and it works very well. People are in stable disease for quite a long time, but unfortunately for the others, we don't have that. So if someone comes in for AML, they get the whole, induction, maybe induction twice, and then they get that consolidation, and so some are much more involved than, say, the CMLs where you take Gleevec every day. So risk factors, if somebody's had alkylating agents for other treatments, it's thought maybe Down syndrome leads to more heme malignancies. So, and people come in with, so how do you know you have a heme malignancy? They're usually very benign. And there again, that's why it's so hard to catch them, because maybe somebody has, my lymph node's swollen. You go to the doctor, the fluid's gone out, Maybe you're short of breath. Okay, well, you're just not exercising enough, So there's a lot of very vague symptoms, but truly the ones that kind of keep people in, do you have night sweats? Okay, that's probably not normal. And then the purpura, the purplish splotches on your skin. So some of them that normal people wouldn't have unless you had a reason, or, those are the ones that kind of keep people in. Let's do more testing. But you can see the rest of them are pretty easy to attribute to something else. So leukemia can be a tricky one to find. Lymphoma. Okay, so lymphoma comes from the lymphocytes, and it also is from the white cells. And so there's two different kinds of lymphoma. There's Hodgkin's and there's non-Hodgkin's. And so what makes the difference between the two? I'm sorry? Excellent. Yep, and they're called Reed-Sternberg. And they're also called owl eyes. When you look at them under the microscope, they look like a big old owl eye. And so Hodgkin's has Reed-Sternberg, and non-Hodgkin's doesn't. So if you look at it in your scope and it's got that cell, it's Hodgkin's. If it doesn't, it's the other. So Hodgkin's is actually a little more curable than the other, and they're treated just slightly different. And then you have to look at how much bulky disease, how much lymph node involvement do they have. If it's bulkier, it's a little harder. Sometimes they get extra lysis, they get on allopurinol because you're going to have all that shedding of tumor once the chemo starts working. So that's kind of the difference between them. So typically with, Hodgkin's, we'll use like ABVD or something like that. And then with the non-Hodgkin's, it's more of a Rituxan, R-shot, that sort of thing. And so the treatments are slightly different on those. So this is the staging system for lymphoma, and it's called the Ann Arbor staging system. So what they do is they take into account your body systems and where you have symptoms, nodes, that sort of thing. So it's really above or below the diaphragm makes a difference. And the other thing I take into account, do you have any other symptoms? And so if you have night sweats, or do you have spleen involvement, that sort of thing. So you'll see, the staging system goes like 1 to 4 as normal, but it might be like, oh, you have a 3B, meaning you have a stage 3 and you have these symptoms. And so each of those tells you just a little bit more about the disease and the prognosis. And so there's one for, if your spleen's involved, do you have extranodal involvement, do you have Broca disease, and so you'll see usually the stage with another letter behind it to try to give you more information about that disease. All right, myeloma. So myeloma is of your plasma cells. And what gets hit with myeloma is your antibodies in your blood that normally fight infections. Somehow the body's putting out a lot. And so they're very immature and they don't let the normal cells work. And it changes how the white cells function in your body. And then they make this, the myeloma tumors produce this monoclonal antibody. And that's how we can tell it's myeloma. So when you get that monoclonal antibody, you'll check the urine and you look for Bing's-Jones proteins because that's a side effect of that protein. You can check the blood, and some of them will actually give you a graph called electrophoresis graph. But it's a graph and it's got a picture and it's got a spike, and that's called your M spike, the monoclonal protein. So how we monitor myeloma is by your monoclonal protein in urine through what's called UPAP, which is a urine protein electrophoresis, or through an SPEP, which is serum. And those can both check for that myeloma spike, the M protein. And then the other part that is a marker is your beta-2 microglobulin. And then beta-2 is one we use for staging. And so what the beta-2 is on those abnormal plasma cells, on the outside of it is beta-2. And so when you run that test, it looks and knows you put this solution on it, and it can pick out all those cells that have beta-2 on the outside of the cell. And then it will give us a levels like 2.3, 3.5, and then those are used in staging. So how many of your cells have beta-2? So when you do the staging, it's your beta-2 level, and albumin is what we use right now because that's a general how healthy are you overall. So that's how we stage with the International Staging System with myeloma. We look at beta-2. But in monitoring, we look at the SPAP, the UPAP, your M spike, that sort of thing. So sometimes they make decisions based on your M protein's higher, your M protein's lower, even if you don't physically have symptoms. So it's a tricky one. It's got a lot of stuff in it. And so what you'll often hear is CRAB in relation to diagnosis, and it's an acronym for what you look at to diagnose myeloma. So C is for, do they have hypercalcemia? Because these myeloma cells will throw off this osteoclast that wants to break down your bones. And so that's why myeloma patients often will present with back pain, or they'll present with femur pain. And when you look at it on x-ray, it's like a moth-eaten or punched out appearance. That's myeloma. It likes to sit at the base of the skull, so they might, gosh, my head hurts back there. They'll do a scan, and at the base of your skull, it's all like eaten out. Your back's another place. And so hypercalcemia is another one. Renal failure, anemia, and then bone lesions. So that's the CRAB. So we'll talk about the acronym to diagnose myeloma: calcium, renal failure, anemia, and bone lesions. And so right now, myeloma has made a lot of treatment progress in the last 5 to 10 years. Right now we typically will use Cytoxan, Velcade, and Vex is typically our treatment. And then we're trying to move transplant up closer. We used to treat and treat and treat and treat and then do transplant, but people have a hard time making it through transplant. So now what we're trying to do is give them initial treatment, get them in remission so that M protein is hardly there if at all, and then we'll transplant them earlier. So that's the idea. And so the monoclonal protein is really the key in the beta-2 that we watch for in this. So, and then men are more affected than women, and the average age is about 65. The next slide is just more talk about that M spike and then some of the presenting symptoms that you'll see. When you see the bone marrow report on this, you'll see they have IgG kappa. What's that mean? Each one has a little different prognostic factor. So the IgG is the immunoglobulin. We all have them in our body. It's a protein, but with this, whichever one just kind of goes crazy. And so, you know, your normal levels will be 30, 40, and maybe your IgG is 300, 800. So that's how they get that. Whichever one is the highest is the number. And then IgG is the most common. And then when you're, just so you have familiarity, but your antibodies are like Y-shaped. And they're made up of what we call heavy chains, which is the immunoglobulins. And then at the very end of the Y are your light chains, and that's kappa or lambda. So when you see the bone marrow report or the blood, it'll say IgG kappa, IgA lambda. And it just tells you a little bit more about that specific so you know how to treat it, what the prognosis is, that sort of thing. And so once they have that diagnosis, they always have it. It'll never switch from an IgA to IgG. That's what they have. Once in a while, they won't have any of the IgGs raised, and that's called non-secretory. Pretty rare, but they think that if you're non-secretory, it's maybe a little bit of prognosis. All right, now I just have a slide on hypercalcemia because it's not only myeloma, but it's in other diseases. So things to look for if they're high or low. Probably the biggest thing I see people present is confusion. Somebody will say, oh my gosh, it's not like you used to be so confused. I think hypercalcemia, it really affects your brain and confusion. And then once you get that hypercalcemia, you treat it with fluids and you treat it with phosphate. Once that comes down, they're like, hey, what happened? I don't even know it. So anyway, think about that. If somebody seems more confused or hard to concentrate, think hypercalcemia. So it can cause arrhythmias and that as well, but that's kind of your typical presentation. All right, stem cell transplants, as you know, we're factor credited here. We do autologous, you can do auto, you can do allo. The only one in the city that does allo, meaning you take it from somebody else and give it to you, which is higher risk for graft versus host disease, is the med center. Those patients get transplanted and then they have to stay in the lead center 3, 4, 6 months. We don't have a hotel like that here, so we do auto. You're in for sometimes even outpatient. We've done a couple outpatient, or they're in for 2 or 3 weeks and they go home and generally do pretty well. Graft versus host for auto is pretty rare. Pretty rare. Most people are engrafted, meaning their ANC is back up, their platelets are up. ANC usually takes 7 to 8 days. Platelets might be up to 2 weeks, and that's called engraftment when both of those in your hemoglobin. You hardly ever have trouble with hemoglobin, but when your ANC, hemoglobin, platelets are all back to normal, then you're called engrafted. So you're still at risk for some infections because we wiped out your whole immune system. So we give chemo ahead of time, wipe out everything, and then give you the cells back. And if people wouldn't get their cells back after we do that high-dose cyanocolin, then they may not live. So the cells are really important. Everybody is always kind of disenchanted that it's only a 15-minute infusion. They're like, really, that's it? You know, it takes them 3 months to work out, get their cells collected, and then 15 minutes later they're done. I'm like, oh my gosh. But yeah, we have pretty good luck with our auto transplants here. So thanks for everybody who helps for those. All right. And this is just a reiteration of what stem cells are. So, all right, last couple slides here. So bone cancers, soft tissues, there's a lot of sarcomas. Usually when you see oma at the end of a word like adenoma, it usually means benign, but sarcoma is its own group. So if you have a question that is, you know, oma, generally think it's benign, but if it says sarcoma, then it's not benign. So there's lots of different kinds, you know, osteo, bone, fibro is, you know, different places where it comes from. So, you know, just think about that. But Ewing sarcoma, of course, is more in kids. It's in the bone. So again, age group and what age. Kaposi's, we'll talk about that on the next slide. But trauma, does trauma increase risk? We don't think so. Sarcomas typically don't respond very well to chemo. And so a lot of times if we can, surgery is a good option. If you do have to use chemo, typically it's an Adria-based, ifosfamide-based, and then from there, who knows, trials. We have a lot of trials right now for sarcoma. But just think about with these again, look at the word and where does it come from, and that'll give you a hint. They're graded either low, intermediate, or high, so I don't know that they actually call it grade 1, 2, 3. They just call it low grade, high grade sarcoma. So similar idea though. And Yeah, I think that's about it. Sometimes with the sarcomas, you know, like Ewing's or such, sounds rather drastic, but the treatment may be amputation. And we had a gentleman that presented and they treated it for something else. I forget what it was, but anyway, it never got better. And then when they saw Dr. Lou here, she's like, oh, it's a sarcoma. And they actually had to amputate it because it had grown so much. And sometimes that's the only way to stop it from continually invading. So with sarcomas, amputations are a common treatment. All right. And then my last couple slides here are just on HIV cancers. And I don't know, do you guys see much? I don't know. I've seen a few patients on with HIV. But the reason I bring it up is just because, you know, HIV right now with the antiretroviral therapy is still prominent, but it's better controlled. But if people with HIV get cancers, there's one type they typically get. The most common one, I should say too, most common one is Kaposi sarcoma, which you all hear about. And it's the one where, you know, on Tom Hanks in Philadelphia, whatever that was called, where he had him on his face and people are like, oh, you're sick. That's KS. And it is a type of sarcoma, but it's really vascular. And so they like to bleed a lot. Typically, once people are started on HIV treatment, those shrink and usually go away. Sometimes when you initially start them on treatment, they get angry and they get bigger and then they go away. Now, the other tricky thing about KS, it can be in your lungs or it can be in your GI system. And if it's there, that's a much worse prognosis. And it's hard to get rid of that. Some people even like cough up KS. So then you have to have an evaluation. Is it in your nose, which we don't worry about so much, or is it in your lungs, which is a bigger, worse prognosis. So normally antiretroviral therapy will take care of KS. And if it doesn't, sometimes a little burst of radiation will help as well. People talk about chemo and such, but I haven't read that that's used as much. It's more the therapy for HIV. The second most common one they get is non-Hodgkin's lymphoma. So if somebody's in with HIV and they have cancer, you can pretty well bet, because a lot of people don't even count KS as a cancer. They count it more like a side effect of the disease. So if somebody's in with HIV and they have a cancer, it's probably non-Hodgkin's. And so the part to remember, you treat it like you would normally treat anybody else, but the heart therapy, the antiretroviral, also affects counts, your CD4, your T cells, and so it can lower all those. So you have that on board, and now you have chemo you're going to give that's also going to lower it. So it's just more of a balancing act to treat somebody who is already immune suppressed. And they've always, the first year they're diagnosed with HIV, they get like every infection possible. I mean, seriously, it's unbelievable how many infections they get. Because like once you get that HIV beaten down, then everything else that was waiting comes out. And you just get one, and then they get another, and then they get another. So it is a really tricky disease. And then if you finally have NHL on top of that, trying to get chemo, it's really a challenge. There's one other type of cancer that is like a pre-non-Hodgkin's, and it can happen in people without HIV as well, but it's called Castleman's. I don't know if you've heard of that. I've only seen a few of those too. But it is like lymph node biopsy is how you find these with them, because they usually present with big lymph nodes or groin, but typically not. And so if they do a biopsy and it comes back Castleman's, then there's debate like, what do we do with that? Because it's like a pre-lymphoma. Does it turn into lymphoma? We don't know. So rather than take the chance, often, you know, for NHL, we'll do R-CHOP. With Castleman's, often what they do is maybe 4 cycles of Rituxan and get rid of the CHOP till later. So Castleman's, non-Hodgkin's would be the ones for this. And then again, chemo, radiation based on symptoms. And then prognosis, if you can get them through with other immunosuppression, would be normally the same as NHL, but it's really tricky balance with other immunosuppression. So this just shows possible HIV-related issues. Lung cancer and some of those others are more rare, but they all have a common factor of being because of low counts. You're more susceptible. Your body can't fight off things like they should. So, and once they're on their antiretroviral, they're on it forever. Never get rid of it. So, a lot of information, I know. I was trying to just hit on the highlights, but you know, my suggestion would be just if you have questions, think about what the word means, what age group I see it in, and then METs are pretty similar for most. How you staged, what markers do you look for? It's a lot of information. There's like over 100 different cancers, so I've only touched on a few. So anything I can answer for you? All right, thanks.
Well, I want to say that I've never talked to anybody for an hour and a half about anything in particular. You know, that's a long time to talk, but if I'm going to talk for that long, this is a good topic to do so because I do feel really passionate about oncology nursing. It's a population of patients that it's very unique. I don't think there's anything like it. And so I do feel passionate about this, the work that we do, and want to kind of share some preparation for the exam. The focus of my preparation is really for the generalist exam. There is some information about standards and such for advanced practice nurses, but I thought that since the focus of this is for the oncology certification exam, that's where we would go. And the topics that we'll cover are standards of professional oncology nursing practice, education, legal issues, ethics, economics, and professional issues. And this section comprises about 8% of the blueprint for the exam. So where to start is just giving a little history of nursing. So our first nurses were either prostitutes or nuns. And they were the ones that were helping. I couldn't find a good old picture of prostitutes to put in there. But these are who started the profession, who were caring for the injured, for the sick. Most people were cared for in their own homes by family members, and the concept of nursing wasn't really formed yet. And then we have Miss Nightingale, who actually was born into a wealthy family in the 1870s, started her career. She felt a calling for God to take care of people, and she actually took care of soldiers during a war. And what was most remarkable about her, I think, is that she took the time to write her observations down. I think other people probably had done work in the area, but nobody had documented it as thoroughly as Nightingale. And she made observations and took stance on things that people listened to. So just kind of a little history of nursing, and I put this in perspective, is that we are really a young profession, and a lot has happened in a really short amount of time. The first ANA convention was held in 1896. Do you know how many registered nurses were there? There were no registered nurses at that convention because there was no registered nurse. Anybody could call themselves a nurse. They probably trained with Sister Louise, Mary Sue, whatever, and were deemed a nurse after they completed so many hours of service within the care facility that they were going to school, became a nurse. And so it was these first group of women, and I think there was maybe 10 of them that formed this first group in New York, wanted to protect the public from our profession. They wanted to give some guidelines and some bones to it. The first journal was printed in 1900, which I think is really important. Kind of goes back to Nightingale in that you write things down, you make observations, you share information with other people. And then the states started forming their own nursing associations, and that's when we started having licensure. But that wasn't until the early to mid-1900s. The ANA drafted the first Code of Ethics in 1926. And to this day, although the media sometimes portrays nurses as being, naughty nurse or being kind of bubble-headed or something, if they take when they take polls for people, nurses are consistently in the first and second positions of being the most trusted profession. And that is because we live this code of ethics. It's built into what we learn in school, what we're asked to do by our licensure and by our professional organizations. So 1969 was, I put this in here just for perspective, is that the first man walked on the moon. So we had somebody on the moon before we had a certification in a specialty. So it's pretty new. It's pretty fresh, and we really owe a lot to those first people that got together and said, we want to protect the public and make standards. In 1973, ANA published the Nursing Standards of Practice, and they soon found out that there were so many subspecialties of nursing, including oncology, that their standards of practice weren't specific enough, because there were certain parts of a job for somebody who works in a neonatal intensive care that is quite different than somebody who is working in an ambulatory emergency department. So there's different professional organizations, and ANA really helps those organizations draft their standards of behavior that are specific to each population. ONS, we became incorporated in 1975. We published our first standards of cancer nursing practice in 79 with the ANA. We're actually on our third draft for standards of cancer nursing practice. The first two were written in conjunction with ANA, and most recently we wrote those independently. And the first exam was in 1986. So that wasn't really that long ago. At least a couple of you were alive then, right? So as of 2013, 34,000 oncology certified nurses. So there's, I'm not sure, that's the most current data I could get. So we are in our professional infancy and come a long way, actually, in a very short amount of time. So the next question is, what guides your practice? So different schools teach in different manners, but we're all coming to a standard place. We have the Code of Ethics, which is by the ANA. Most organizations that you work with also have a Code of Ethics that you should be familiar with. Your licensure, which varies from state to state, also defines what your scope is and what you should be doing. There's federal statutes, standards of practice, policies and procedures, and then the nursing subspecialties, which is the standards for oncology. There is a very nice, first, what is the word standard? Because we're going to hear this a lot. All the topics I'm going to talk about today, standard of care kind of goes through all of them. When you talk about legal issues, that's the first thing that comes to mind is what is the standard of care. But it's the ideas about being correct. It's a standard at which you compare yourself. It's a quality level, achievement level, and this is what's considered acceptable or desirable. So the standards provide the framework for which you practice in. So what do you think the difference is between being an oncology nurse working in a clinic or a clinic nurse who takes care of somebody who has cancer? Do you think I could float to the orthopedic unit tomorrow and say I'm an ortho nurse? Probably not. So, because what it takes is that having an identity, and that identity doesn't just come with you calling yourself that. It's taking a personal initiative to develop knowledge in an area and be professionally involved. At that point, you can call yourself an oncologist. So the ONS has this book. I actually had to order one because I have read parts of it before, but I had never read the book cover to cover, so I had to order a copy. So anybody wants to borrow it, I have it in my office. But this book is broken up to historical, which we've already kind of covered, the scope of oncology nursing practice, the standards of care, and the standards of professional performance. So the first thing they talked about were what are some of the forces going on that impact a nurse's practice. And a lot of them come from recent years. There's been a lot of government regulation that's changing our practice, finances changing ours, and also this focus on keeping patients safe. And because there's all this change going on, obviously our professional organization is taking a stand because we want to be at the table when we're making decisions about how healthcare looks in the future. Although Nebraska is a state that doesn't give a lot of autonomy to the nurse practitioners, that will be up for vote again, I'm assuming this year. And so being verbal, being proactive to support our profession is important. So they did talk about some states not being able to practice at their full potential. And they also talked about higher level of education and training, that BSN would be an entry level, that nurse practitioners would be a doctorate level. They talk about what's going on with patients and families, and that people are living to be older, and so we heard from Kim that one of the major risk factors for developing cancer is just getting older. If you live long enough, that may be something that you experience. And we also live in a society that is very death denying, and that we are so used to fixing things that we just don't. If it can be fixed, we want to, whether it should be fixed or not. And that's really playing a kind of a dual role with the financial state of our healthcare. And cancer, because although Kim kind of left me depressed as far as the life longevity for people, but there are many, many people that are living with cancer in a chronic state. So maybe they're not cured, but their cancer is controlled and it's become a chronic health problem as opposed to something that's going to immediately take their life. So obviously the scope of oncology nursing practice is very broad. We have nurses that work in clinics. We have nurses that work in hospitals. We have oncology nurses that do programming for entire populations. We are doing research. We're involved with that, and so it's very broad. And not only is where we practice broad, but also who we're considering our patient is not just the patient that's been diagnosed. You're also treating communities, and when you treat somebody with cancer, you're treating their entire family. So they talked about, in this booklet, about a generalist level requiring cancer-specific knowledge beyond what's offered in their basic nursing practice. And so I'm really, again, very happy that Heather's put this together, because I think having this on videotape and sharing it with people will be kind of a stepping stone to those people that are just needing some basic knowledge. The scope requires that the oncology nurse works collaboratively with a lot of other disciplines. And when we get into the next section, we'll talk more about the diagnosis and assessment. So just earmark this for the exam. There may be a question about the high incident problem list. So this is something, although there is some of this in the ANA standards of care, these are the 14 areas that are specific to the oncology nursing standards. And these are what they're recommending, that we evaluate every patient on these high incident problems. So education, their coping, sexuality, cardiopulmonary function, oncology emergencies, survivorship. So if most people's assessment tools will be built around having all of these elements covered. So Like I said, the book also covered the scope for the advanced practice oncology nurse. And I put just one screen on this because I was trying to focus on the basic exam. There is no curriculum for advanced practice RN in oncology. They do the acute adult track typically, but there's not a specific oncology curriculum at this time. But there is advanced certification available. So the standards of oncology nursing practice are broken up into two parts. There's standards of care, and then there's standards of professional performance. So standards of care is really about what you do as a nurse, and standards of professional performance are about your behavior as a professional. Isn't this really interesting stuff? All right. So standards of care, like I said, it's the activities of an oncology nurse. And it kind of goes back to what you learned in basic nursing school about assessing, diagnosing, setting goals or outcomes, planning, having interventions, and evaluating, reevaluating. And that is the framework that they use for standards, for the standards of care. So in the assessment part would be meeting with a patient, a client, a population would be to collect data in the 14 high incident problem areas. Remember I said that that's kind of a big deal as far as our standards. You'd want to have your tools, your assessment tools built around these 14 areas. And then so the assessment would be collecting data, and the measurement of whether this is being done or not would be that it was being done in an unbiased and competent manner. And you would be using evidence-based assessment techniques and communicating in a timely manner with interdisciplinary teams, because most care plans would not be done just with an individual nurse. They're usually multidisciplinary. Diagnosis, so after you're done doing your assessment and collecting your data, you create nursing diagnosis. Carrie, can you tell me how you do this as an outpatient? Do you have nursing diagnosis?
No. They have recently, as a nurse navigator, they have created a special documentation band that does document the psychosocial stress tool that we use and their evaluation for obstacles to their care, resources, and then referral for those resources.
So some of those,
but we don't, it's not necessarily with your traditional care plan.
like a NIC-NOC, NANDA kind of problem list.
But it is very interdisciplinary, which is nice.
And then radiation, do you use?
Yeah, we're using the same tool.
Same tool. Okay. So by doing your assessment and then developing some sort of diagnosis, you're deciding that action needs to be taken in certain areas. And then you would prioritize what you want to do first. And then you would set goals for the patient, and they should really be reasonable and realistic. So it might not be for, it might be for, if it's a coping issue, it might not be that they're without distress, but maybe that it's manageable and be evidenced by a certain behavior, that they're sleeping at night, that they're able to eat, that they're exercising, that they're making eye contact. They should be reasonable goals. And planning would be the next step of the standards. And so you would make interventions around the problem areas that you've identified. And it should be patient-centered and include the patient. When you're doing planning, you can't make a plan without having the other party involved and making sure that they're part of the decision-making. And then implementing. So your interventions, whether it be seeking counseling for a coping situation, or if it's pain, whether you've sent them a referral to the pain clinic, or you're trying some heat and ice, or you're trying massage, you would list your implementation, you would implement your interventions, and make sure that they're evidence-based. And then you want to evaluate, and you do that at regular intervals. And make sure you're using your resources. There's lots of resources, I think, that are left untapped for oncology patients. So standards of professional performance, this is not so much the things that you do, but how you behave, or your behaviors. And it's really a self-motivated journey. It's not something that somebody's going to make you do, but you have to want to do it. And I will tell you, at the other end of doing those things, being committed to lifelong learning, being professionally involved, there's rewards that come with that. They're a little bit different for everybody, but it makes you feel a part of something. So one is following a code of ethics. So we, the oncology nurse, will follow the AIM code of ethics and conduct themselves in a professional, ethical manner when they're around patients, when they're around coworkers, when they're in general public. I often tell employees that if they're on Facebook and they're representing themselves as part of our unit, that they need to keep that in mind when they're posting, that they need to keep it professional because you're representing part of our unit. Be respectful of differences. Have some basic knowledge of genetics, and they threw that in because education is part of the requirement of a professional nurse, so you would need to have some basic knowledge to answer questions and respond to any ethical concerns. Maintain confidentiality, and point out any unsafe practices that you see. And that's probably one of the hardest things for people to do, is to make public things that are not done as they should be done. And education, this kind of goes across, all nurses have to do a lot of educating, but this is the cancer patient has so many learning needs, and they are at such an emotional level, sometimes it's hard to find the right opportunities, but you need to make sure that you're evaluating that as part of your assessment, their education needs, continually. And it's not learning just at the beginning of their diagnosis, but throughout their journey of treatment, and using evidence-based research again. Then they also talk about your personal education, and that you need to take opportunities of learning new information, whether it be about a new treatment option, a new, just coming to this, although this section is kind of dry. But taking advantage and obtaining your certification. It's not really having those initials after your name. It's the journey of learning all the information that takes you there. And then research, keeping up on the latest research. One of my annual goals every year is to read. I list how many articles that I want to read in a year as one of my personal professional goals. But however you do that, and they mention critiquing studies, belonging to, I don't know if you have UBCs or our unit-based council. We've done that in the past where we kind of share information together. So again, this is quality of practice. This again, belonging to interdisciplinary teams, evaluating patient satisfaction, being aware of what you're being held accountable for as far as your nurse-sensitive indicators, what you can impact and measuring things, not just doing your work without reevaluating where you're at, and asking for feedback. Communication is a struggle in whatever field you're in, but being aware of how you personally communicate and how you is very important when you're starting communication with your peers or with your patients. And then being able to set up communication without barriers, language barriers, cultural barriers. And professionally, we use a lot of communication when we're, as far as a patient safety tool, as whether we're handing people off in a safe manner and covering all the information that we can. So, leadership. The oncology nurse is asked to be a leader, to mentor other people, to advocate for the patient, to be knowledgeable of resources and putting their patients and their family members in contact with those resources at all times, and motivating others to want to be involved, be certified. And that's part of being part of a bigger team. A lot of times the nurse is the one who spends a good amount of time with the patients and can help really advocate for them. The physician is part of that team, our social workers, dietary, outside resources, but the nurse is a lot of times leading those collaborative endeavors. And delegation is also part. Professional practice evaluation. So hopefully you all are involved in some sort of formal evaluation as part of your job. But a lot of people take this kind of lightly and don't put any work into it. They kind of go and they hear what their supervisor has to say, but they don't go in with this really wanting information and kind of expressing what your goals are, career goals. Because if you don't take a piece of paper and write down your career goals, you'll really never act on them. So the evaluation process is a good opportunity to do that, to see where do I think I am, where does my supervisor think I am, where do my peers think I am, what are my opportunities, what are some things that I haven't even thought of that I might be able to do professionally. Have any of you gone to Congress in the past, Oncology Congress? It's pretty wonderful to see all the different things that people are doing in our field, all the presentations and the innovation, and it's nurses just like us that are publishing articles, that are giving presentations, that are coming up with new and better ways of doing things, and it just really kind of inspires you to kind of take action in your own professional life. And then also providing feedback to your colleagues when you are asked to do a peer review, to take that seriously and be able to give them good information to act on, not personal information, but things that could benefit them. Sometimes people's feelings get hurt, or they don't want to hurt someone's feelings, but you can present the truth in a way that it can be taken. And then being a role model and mentor and maintaining a professional portfolio. So if you don't have a CV or some sort of resume that you update routinely, you should start that as a professional. And knowing your resources. Technology obviously is a big part of our resource now and sharing information, but don't forget the use of communicating verbally as well. Collaborate with other disciplines and really looking for patients and families' needs. American Cancer Society here in Omaha is a wonderful resource to patients. They have travel, they help people with travel, they help them with durable equipment, as well as a lot of teaching information. And as a professional, your behavior as far as keeping your environment, your patients, and yourself safe, and promoting a safe environment by using the proper PPE, and calling other people out when they're not using it. So I have a couple practice questions over this section. So what would the standard of care from the Oncology Nursing Society statement on the scope of standards of oncology nursing practice can be used to what? Assess performance indicators, assist in development of performance appraisal tools, determine the performance role for different levels of nursing, or help meet JCAHO standard. Because when you go to take the test, you will find that all the answers could possibly be the right one. But the best answer in this situation is to assist in development of performance appraisal tools. Because every organization will probably take the standards to fit their own needs. Next question is the 14 high incident problem area included in the statement on the scope and standards oncology nursing practice includes A, areas that the oncology nurse must assess, plan, and intervene. B, cancers with the highest incident rates the oncology nurse will care for. C, measurable performance indicators for oncology nursing. Or D, problem areas the oncology nurse must intervene in the acute care setting. It is A. Thank you. All right. Does anybody need to stretch? If you do, we'll keep moving because I think we'll be done a little early. Next is the education process. So prior to doing teaching, how do you know your patients are ready to listen or ready to hear what you have to say?
Hopefully you have an established relationship with the client, so you kind of know something about their personality. Maybe simple things like maybe eye contact and actually showing that they're interested.
Right.
Maybe asking questions.
Mm-hmm. And that is really the biggest part, is finding out where they're at and what they need to know before you even start it. I think a lot of times education becomes one of those tasks that we clip off our list of things to do without first seeing where the patient is to find out exactly what they need, and then customizing it to their needs and not making it a standard spiel that you teach or say to every patient. Patients are empowered by knowledge, and a lot of patients now use the internet to search, and so making sure that you put them in connection with good sources so that they're not reading, they're not getting all their information off of Google sites that might not be worthy. And then trying a variety of modalities and approaches. Some people don't like to read information, and some people don't like to watch videos. Some people need hands-on instruction. And you should be measuring outcomes for education at all times. Literature says that if a patient is mildly anxious, they may actually retain information a little bit better. Now, if they're grossly anxious, you need to find another time. So the other thing is to consider when assessing learning needs is to assess the person's literacy, whether they, if you ask them if they want a handout and they really don't want that, you don't necessarily have to embarrass them by saying, can you read, but by asking them how do they like the information, will guide you. And then also consider that the majority of people read at a 5th grade or lower level, and we have so many abbreviations and letters and big words that we use in our language when we're trying to talk to patients that we really have to make sure that we are keeping it simple and plain. And consider comprehension abilities. We started on the inpatient side doing the teach back, which has been, I think, very beneficial. It kind of double checks that people are hearing what you have to say. And if you're developing an entire program for a population so that you're going to be going out into the community and teaching people about skin cancer prevention, when you do that, you want to have specific goals and have them written, have material that you're going to hand out, and also evaluate at the end whether you've met your goal of what you wanted to accomplish. So education process is seeking new opportunities, addressing challenges, working together, and building on past successes and strengths. So a couple questions on education. The nurse educator is responsible for developing a public education program regarding breast cancer. Information the nurse must assist him or her in the development of this program would include date, time, and where the program will be held, knowledge of the JCAHO standards, what the nurse feels is important for them to learn, who the target audience will be. Yay. The nurse is attending a second meeting with a client who has a new ostomy after colon surgery. At the first session, the nurse reviewed basic information with the client, and he appeared to be eager to learn how to manage the ostomy. The nurse gave the client printed material, and the client said they would read it later. Today, the nurse asked the client if he had read the material, and the reply is, "I have not had my glasses here, so I gave it to my wife to read." The nurse might suspect the client, A, does not have money for glasses, is depressed regarding the ostomy, has a low IQ, D, may have literacy problems. Yay. Okay, so legal issues. This is again from the Institute of Medicine. More patients die each year from adverse events associated with healthcare than expire from automobile accidents. Has anybody been depositioned here before involving the case? Helen's nodding her head. Yes. I've been depositioned twice. One was for a pressure ulcer, and I happened to be on the patient's, I had cared for him at one point during his stay, and the other was for a fall that resulted in death. And your best, and a lot of times these lawsuits do not come until 2 years after the actual event. So your two best defenses in protecting patients and protecting yourself is your standards of care and being aware of them and acting on them, which is a thorough assessment, thorough interventions that are evidence-based, and reevaluating. Your next big protection is your documentation, because if you don't document, it didn't happen. So there's two types of law in the United States. There's criminal law and civil. So criminal is guilty, not guilty, and civil is that you're liable or not liable. But both types apply to health care, and civil is more common. So in civil law, defendants, again, are found liable. And the reason I think that there's more civil suits is because there's usually a financial reward for the people that are planning the suit. Yes. So tort law defines the civil laws. It's an action that wrongly causes harm to someone that is not a crime and that is dealt with civil court. So this isn't the right kind of tort. Barb, that's a beautiful picture. There are two types of torts, unintentional and intentional. And unintentional are the basis of most malpractice suits, and they involve negligence, whether it's carelessness, an accident, and results in injury or harm. And negligence is a failure to use the degree of care that a reasonable person would use under the same circumstances. And for the plaintiff to win the suit, they have to prove each of these 4 areas. They have to provide proof for each of these 4 areas, that it was the legal duty to provide reasonable care, that a breach of duty, whether it was an act or a failure to act, took place that resulted in an injury, and the breach of duty was the immediate cause of the injury. An example would be somebody fell out of bed and their bed alarm wasn't on. So is the bed alarm not being on, is it the fall a direct result of that? That goes to court. Do you ever read The Legal Eagle? It's a publication that kind of goes around the health system. It's really good. It has all kinds of cases like this. Medical malpractice is the professional's conduct did not meet the standard of care. So again, we talked about that at the beginning, the standard of care, and that is the first thing that the defense will investigate. What is the standard of care for this area of the country, or this organization, this community, and was it followed? And they usually have to kind of, because what we do here in Omaha, Nebraska might be very different than something that they do in Outback, Alaska. And it's not just geographical, but it's cultural impacted and geographically impacted. So the top 6 nursing negligence areas are failure to follow standards of care. We keep hearing that. Failure to use equipment in a responsible manner because you didn't turn on that bed alarm. Failure to communicate, which I think is getting even more complex with the more we have computers, because we just miss out on, you send out a message, but you never really confirm that somebody heard what you were saying or even understood what you were saying. There's something missing when you're just basing it all on technology. Failure to document, this is a big thing, and if it's not done, if you didn't assess somebody's emotional state and they come to harm's way, not that you'll be taken to court over that, but you're missing an opportunity there. Failure to assess and monitor, and failure to act as a patient's advocate. So intentional torts is when a conscious decision is to do something, because in a reasonable mind you know what the consequences will be if you do this. Defamation, false imprisonment, and assault and battery are examples. I will give, we don't use them very often anymore, but I'll give an example of restraints. A reasonable mind would know that if you didn't release somebody's restraints routinely or assess that something bad could happen to their skin, and that could be considered an intentional tort. So criminal law also is covered in medical cases, and it would be considered a misdemeanor or a felony, and it's criminal negligence, reckless disregard for the safety of others. So a couple legal questions. An advance directive is a durable power of attorney. A medical power of attorney communicates a patient's decisions about medical care as a living will. And litigation for malpractice will most likely involve what legal situation or action? Sanctions by the institution, sanctions by the State Board of Nursing, settlement out of court, or trials by jury. Actually, D, trial by jury.
For the 2 years of trial?
Hmm?
For the 2 years of trial?
They were both settled.
Litigation goes to court.
Mhm.
That's the key word in that.
Yes. So ethical issues, ethical principles include respect for person, beneficence, meaning to do no harm, promote good, justice, which is fairness, and obviously ethical theories are useful when formulating committees. Are any of you familiar with ethic boards? Or at Methodist we do have policies regarding how we handle ethical decisions, and we actually have a group of people that are pulled together when we do have ethical dilemmas, and we use a model, which is a 4-quadrant model, where we identify the different areas of the situation and try to come to a rational decision. So these are some of the terms for the test that you should be familiar with: autonomy, beneficence, competence, capacity, informed consent, non-maleficence, slippery slope argument, and value. And I'll give you a couple ethics questions. Social Security, Medicare, and Medicaid exemplify the principle of justice. A client has agreed to participate in a clinical trial. She approaches the nurse and says, "I'm worried that my insurance company won't cover the cost of the clinical trial." The best response would be, "Can you afford it? I'll make an appointment with a financial counselor. I'll let your physician know, and I will speak with your case manager." D. It is D. Part of professional practice is navigation as well, because we all kind of act as navigators and helping people through this really complex system. And then cancer economics and healthcare reform. So these are statistics from the American Cancer Society from 2014, in which they stated in 2009, cost of cancer was $216.6 billion. And 2 years later, in 2011, 48.6 million people did not have health insurance. So becomes to be the economics of care becomes a big issue for the population we care for. So the Affordable Care Act, a lot of people say, no, government should just stay out of the healthcare business, but they're actually our #1 payer in between Medicare and Medicaid patients, and that's going to become even more significant as our population ages. So although maybe we didn't like this, people call it Obamacare, there were changes that were coming whether this happened or not. But the goal of Affordable Care Act is to extend coverage to the uninsured. This is a little, this is out of the Washington Post, and these are predictions. If you can see, the blue line is no without health care reform and with health care reform, and they hope to steadily reduce the number of people that are uninsured. Some other facts about the Affordable Care Act. It's extended Medicaid. They extended that to people who are not just at poverty, but at 133% of poverty. And then low-income families who previously couldn't afford health insurance will be given some tax credits so that they can help pay for private insurance. And there is a cap on your premium, so if you do make a decent earning, they're not going to make you cover the cost of everybody else by accelerating it to the maximum of your ability. Coverage is mandatory and fines will be assessed. Small businesses that previously hadn't been providing health coverage to their employees are going to get some tax credits as well. Insurance companies cannot discriminate based on pre-existing conditions. This is really important for the oncology population. But they can discriminate on tobacco use. I didn't know that, but I know. There are also built into the future that aren't enacted yet some new laws that are going to help incentivize employees to pick reasonable plans for their employees. And insurance companies have to spend 80% of their premium dollars on medical care as opposed to keeping it within their company. So. Characteristics of managed care include which of the following? Ability to choose among physician groups, episodic financially focused care, standard practice guidelines determine reimbursement, or unlimited use of referrals to support services. That is correct. And competing economic demand that has reduced governmental funds available to address the nursing shortage and care for oncology patients. Aging of Americans, cancer prevention and detection, cost to maintain quality of life, and increase in clinical trials. Yep, that is correct. So you guys are all ready to test. So professional issues. Again, it talks about certification and how it increases your knowledge. So even if you weren't taking the tests, if you just went down the journey to prepare for it, is taking you into learning things that you didn't know before. And you're constantly adding to your lifelong knowledge base. It makes you more confident with your patients, and it is rewarding. And it also protects the public. I think that's the first nurses that met in New York City for the ANA. They wanted to protect the public. It's collaborative, a state of continual learning, advocating not only for our patients, the populations, but for our profession and being good communicators. The scope of oncology nursing practice, A, defines the practice of oncology nursing across care delivery settings, defines the role of all health professional with oncology clients, defines oncology nursing practice in a hospital setting only, defines professional responsibilities of the nurse engaged in oncology nursing. That is correct. You will find when you test, though, that a lot of the questions sound okay. You have to pick the best one. And what is the main purpose of oncology nursing certification? Define the role and responsibilities of the oncology nurse. Ensure the safe practice of nurses who provide oncology nursing care. Increase revenue to the certified nurse and the institution. Upgrading the nursing service in which the certified nurse practice. That is correct. That is it of my presentation. Do you have any questions?